happy birthday, Parna.
Thank you.
Thank you.
हो ठाणे आहे से कातकडे सर
Katkade sir.
Thank you.
Congratulations, Katkade sir.
Yeah. Thank you. Thank you. The association of ISA Thane has grown very fast. Let me be very honest. Last 7-8 years we have done it.
Yes.
Credit goes to every member. Dr. Parna is very active
Yes.
and will do great now.
Thank you. Thank you.
Dr. Anita Madam, our last CME was also very good. National CME was superb.
Yes, that CME on mental health by Dr. Nadkarni.
Yeah, that was the webinar. But earlier that, the CME at Thane, Satkar Grandi.
CME and Thane, yes.
National CME.
They might come, na? Anita madam was there.
Yeah, Dr. Anita Madam was there. Yeah, of course. Dr. Rajesh sir did take it.
Yeah.
Actually, 6 o'clock.
सहा झाले.
Dr. Devatia sir hasn't yet joined, so
I think we have to wait for him because he is the first speaker, no?
he is the first speaker, yes. I can call him, and if he says, because our introductions may take around 5 minutes, so I'll just call him once and
पर्णा मॅडम आवाज येतोय का व्यवस्थित?
हा आता बरोबर
Okay.
now. Sir, all well.
Rajesh, we can start. Devatia sir has just joined, he said.
Good evening all dear SAMS members. I would like to welcome Dr. J. Devatia sir, our past president of IISc National, and Dr. Vijay Shetty sir as a speaker. And I also would like to welcome Dr. Charulata Deshpande madam from Nair Medical College and Dr. Balaji Asegaonkar sir, our past president of SAMS. Today I am happy to continue our webinar series that is Safe Anesthesia Saves Life. And today's speakers are Dr. J. Devatia sir and Dr. Vijay Shetty sir. I would like to request Dr. Anita madam to brief about our webinar series.
Thank you, Rajesh. Good evening, everybody. The theme of our webinar is Safe Anesthesia Saves Lives, and today's topic is optimization. We see a lot of patients who are very, very sick and patients who have thick files, and we don't know where to start. And on the top of that, the patient is in Marathi, what they say, Sarva Guna Sampanna. The patient has all the diseases. And the physician says that the patient is fit with due risk. So, I mean, though the physician says this, can we take up this patient or we need to optimize? So, let us hear from our today's experts, and without wasting much time, I will start our first chairpersons. I will start introducing Dr. Balaji. Welcome, sir. Dr. Balaji Asegaonkar, sir, actually doesn't need any introduction, and he was the immediate past president of Maharashtra Society of Anesthesiologists, and he's a consultant anesthesiologist in Aurangabad. He's a director of Ozone Anesthesia Group, and he is a leader of around 40 anesthesiologists who work under him in the Ozone Group. And he does a lot of social work, and he takes care of Sneha Savli Care Center, which is a palliative care unit. He has many achievements to his credit, and he has done heart transplants and written books and has done certificate courses in geriatric medicine, palliative care medicine. He has many publications, and he has received a national level proficiency award and diligent award. So a very accomplished speaker and a cardiac anesthesiologist. I welcome you, Dr. Balaji, sir.
Thank you, madam.
I request Rajesh to do the next
I would,
introduction.
yes, I would like to introduce Dr. Charulata Deshpande, madam. She is a professor and head of the Department of Anesthesiology in BYL Nair Hospital for more than 30 years, and she has more than 20 publications and chapter contributions. Areas of her interest are cardiovascular, anesthesiology, and airway. So this was about the Charulata madam.
Thank you.
Parna ma'am.
Sir Parna,
Yes, yes.
please introduce Dr. Devati.
Yes, yes, sir. Good evening, all. Dr. Jiggy Devatia, he doesn't need any introduction, and he's, I think, one of the most popular anesthetists and teachers whom I know. He's the head of critical care, Leelavati Hospital and Research Center, Mumbai. He's the past president of Indian Society of Anesthesiologists, past president Indian Society of Critical Care Medicine, past editor-in-chief Indian Journal of Anesthesia. He has over 210 publications, H index 40, and areas of interest are mechanical ventilation, airway management, hemodynamics, and end-of-life care. Welcome, sir.
Hi, good evening. I hope you can hear me.
Yes,
Yes,
yes.
Yeah. So thank you very much, Sams, for inviting me to speak here with you. So the topic is pre-op respiratory optimization. Okay. So I hope my slides have come up.
Yes, sir.
Uh, okay. So thank you very much again, and apologies for me joining a little late and trying a little tied up over here. But okay. So when we talk of preoperative optimization of the respiratory system, essentially what we are trying to do is to make sure that the patient has a smooth intraoperative course, and we want to avoid postoperative pulmonary complications. Now, postoperative pulmonary complications are not uncommon, and they occur in almost 3% of patients having non-cardiac, non-obstetric surgery. And although it seems to be a small percentage, if you see the higher risk patients, it's actually, can be quite high. And in patients who are in ICUs or who undergo major surgery, almost 20 to 40% of patients can have post-op pulmonary complications. And there is some literature which suggests that they are more common than cardiac complications, which all of us are very worried about. Okay? And therefore, the aim of any pre-operative evaluation and optimization will be to reduce post-operative pulmonary complications. So the aim will be to do things to identify high-risk patients and then to do things that will prevent post-op complications. Now, we know that anesthesia and especially surgery, not so much anesthesia, but also surgery, produces a change in respiratory function. And the closer the surgery to the diaphragm, that's upper abdominal surgery and definitely thoracic surgery, can produce profound changes in function of the lungs as well as the chest wall. And, so there's a reduction in lung volume, and which continues into the post-op period because of diaphragmatic dysfunction, pain, muscle splinting. Therefore, there is atelectasis, which happens with the induction of anesthesia, surgical maneuvers, head low position, pneumoperitoneum, all those things cause atelectasis of the lower zones of the lung, and therefore you get impaired gas exchange and hypoxemia. Of course, there's respiratory depression because of some of the drugs we use, and there is impaired cough and mucociliary ciliary clearance because of cold gases, of lack of humidification, lots of other sort of issues, just prolonged ventilation, intubation. All of that can cause complications. So these are going to happen in many, many patients, and the higher risk patients are obviously going to have a higher incidence of complications related to these things that happen in the intraoperative and perioperative period. And, it is, again, very evident that patients who have respiratory disease pre-existing, now there are lots of diseases. Of course, one is COPD, then you can have interstitial lung disease, which we are diagnosing more and more commonly. So any preoperative respiratory disease, history of smoking is, again, they are likely to have complications. Patients with asthma, COPD, and obstructive sleep apnea are extremely prone to post-op respiratory complications. And we need to identify these high-risk patients, and these are sort of self-evident. But I'll talk to you a little later about how we can optimize these patients to actually minimize the risk from these kind of patients. Now, when you have a patient coming up for major surgery, one of the first sort of, and with a respiratory comorbidity, one of the first things to identify the risk, right? So everyone is not high risk. So, and you cannot blast every patient with a whole load of interventions to reduce post-op pulmonary complications. You need to sort of focus on the intermediate to high risk patients. Now, when you talk of preoperative risk, right, some of the factors are fixed. You can't change them. For example, elderly patients, the age, the gender, the genetic predisposition of some patients. So those are sort of, you cannot change them. There are some which can be modified. Now, and they can be either acquired, for example, anemia, COPD, and diabetes. Now, here they're all fixed as well as modifiable. In other words, if you have COPD or diabetes, you're always going to have COPD and diabetes. But you can obviously modify the cause of COPD, by taking care of the COPD, preventing bronchoconstriction, taking care of infections. Diabetes can be controlled, hypertension can be controlled. So these are fixed and acquired, but they are modifiable, and you can reduce the risk. And of course, there are lifestyle changes which can be changed. For example, smoking, alcohol, make patients exercise, not reduce sedentary activity. So these are modifiable risk factors. And all these things have to be sort of taken into account when you treat a patient with comorbidities. And of course, as it is, nowadays the buzzword is everything has to be collaborative. It has to be in sync with the patient and the family and all those things. And if you want to do some lifestyle changes, then of course you need some behavioral changes. So this is sort of principle around which we are going to do. Now, so let's take an example of this patient who's undergoing a Whipple's surgery. So, he's a smoker. He's been a smoker for many, many years. He now claims that he has reduced his smoking intake, but otherwise he used to smoke fairly heavily. He's got a diagnosed COPD. He was wheezing last week. There was no fever. His sputum is white. There is no infection. His saturation is 92% on room air. He's taking regular treatment with bronchodilators and inhaled steroids. So effort tolerance is not great. Okay, but otherwise he seems to be okay now. So this is most likely a high risk patient, right? All of us will identify this. Even a ward boy will tell you that this patient is high risk. One is because he's got COPD, he's been a heavy smoker, and effort tolerance is moderate, and he's undergoing a major upper abdominal surgery, which is going to last for a pretty long period of time. Now, this is a sort of traditional evaluation which you would do for these patients. So one of the things about optimization is to identify the patient who needs optimization the most, right? That doesn't mean you don't do anything for any other patient, but some patients really we need to focus our attention to prevent complications in patients who are definitely at high risk of complications. So one would be you would see the grade of dyspnea which you can grade. Okay. So I'm not going to go into detail about the sort of workup which you would do, but we would definitely want to look at things like the X-ray chest, the ECG, and we'll talk about the role of pulmonary function testing and EVs. Now, in COPD, you can get various sort of pictures depending on what the patient has. You can get or what disease the patient has. Now, this one is COPD, but you could have some of the interstitial lung disease, right? Or a CT scan. So these are all things with the pulmonologists and the physicians and us. We have to work together as a team and find out what is the problem and how it's going to be treated. Focusing on the respiratory system, we need to define or determine what is the extent of effect, how badly the lung is affected. And one of the ways is to do pulmonary function tests, right? Now, please remember that pulmonary function tests are not to decide on fitness for anesthesia or the type of anesthesia, but mainly it is to determine what is the severity of impairment of patients who have known respiratory disease if the physicians are trying to optimize the patient, then what is the course of, how is the response to treatment? And then you can assess the risk, right? It is a risk assessment tool. It is not a fitness tool. And it's a risk assessment to predict the risk of post-operative complications. Okay, so this is essentially the role that we are going to have as far as PFTs are concerned. And the pulmonary function assessment has 4 or 5 steps. The simplest and the commonest is spirometry and arterial blood gas monitoring, right? Split lung function is more specialized and it's confined to thoracotomies and lung resection surgery. So I won't go into that. We are just focusing on optimization for non-lung resection surgery, because I think that's the commonest sort of surgery which you're going to do, whether it is major laparotomy or whether it's laparoscopic surgery or robotic surgery with head low and steel, Trendelenburg position and all those kind of things. And there is some role for formal cardiopulmonary exercise testing. So simple things we can do at the bedside is this breath holding time, which is a measure of the decreased cardiopulmonary reserve. So it tells you that there's a problem. It doesn't tell you whether the lung is a problem or the patient severely anemic or he's got small mild heart failure or what it is, but it just tells you that this cardiopulmonary reserve is reduced. And all these still tell you about the degree of obstruction. I won't go into that, but of course for postgraduates, these tests are extremely important and examiners will always harass you for these sort of tests. So now, again, like I mentioned, the PFTs should not be done as a matter of routine just because a patient has a history of asthma. If he's absolutely no symptoms, he has not wheezed for the last 6 months or 1 year, there's probably no reason to do a PFT. But if the patient has a history of smoking or dyspnea, right, and is undergoing a major cardiac or upper abdominal surgery, probably do, right? If they're undergoing lower abdominal surgery, if there are symptoms or a history of smoking and there is prolonged surgery, for example, a robotic prostatectomy. Okay. Then patients who don't know what the kind of lung disease is, maybe, and of course, there is required in all patients undergoing lung resection. So there is a very specific role for PFTs, and it is not to give fitness, but to basically decide on what is wrong with the patient, how bad is it, and what is the response to treatment, and then to sort of risk stratify the patients. Spirometry is very common, and COPD is probably the most common sort of condition that we come across. And therefore, again, that is to assess the severity of airflow obstruction. Okay. How can we use pulmonary function tests to identify increased risk? So one is, if any of your spirometric indices, that is your forced vital capacity, your FEV1 and MVV, or the diffusing factor of the lung for carbon monoxide, which is a measure of predictor of diffusion, are less than 50% of predicted, okay, then it tells you that this patient is at increased risk. Right? So basically, very simple cutoff is 50% of predicted for their age, gender, and body weight. If you add blood gases to this, right? If you add blood gases to this, if your FEV1 is less than 1 liter, now that less than 1 liter is actually quite low, but your PO2 and CO2 are normal, you're still in the low risk category. If your PO2 is low, but your CO2 is normal, you're in an intermediate risk and you're likely to require prolonged oxygen therapy. But if your FEV1 is less than 1 liter and you have a low PO2 as well as a high CO2 at baseline, then you are very likely to require mechanical ventilation. So again, the idea for this is to be prepared to try and optimize these patients even better, and of course to prognosticate and to counsel the patients that this is the problem with you and this is what is likely to happen to you. So these risk stratification is extremely important. It is now becoming more common to do cardiopulmonary exercise testing. Okay. And essentially, what is CPET or cardiopulmonary exercise testing is an integrated global assessment. Again, it's a global thing because you're exercising and you're monitoring the response to exercise. So it assesses your lung function, cardiovascular, and hematological system, right? And it assesses how your body performs when you are exercising, that is under stress, and that sort of indicates a degree of physiological disorder. So again, it's a global assessment, and you can the whole fundamental principle of exercises testing before surgery is that, when you exercise, you need more oxygen going to your tissues. And in order to deliver that oxygen, your ventilation needs to increase and your cardiac output needs to increase. And then your muscles will not get fatigued and your muscles will function optimally. Right? But if there is inadequate oxygen supply to the tissues, either because of the lung problem or a anemia problem or a cardiac output problem, you will show signs of anaerobic metabolism very early, and you will not be able to reach a very high oxygen consumption. And then the next assumption that is made, that the physiological exercise to exercise will be similar to the physiological needs or response during major surgery. So in other words, if you can tolerate exercise to a certain limit, you are likely to tolerate major surgery. If you're not able to tolerate exercise below a certain limit, you're unlikely to be able to tolerate surgery. So now, what sort of cardiopulmonary exercises testing we can do? One is what we call as fixed challenges. That is, the common ones are stair climbing, and very commonly what we use is the 6-minute walk test. Okay, so that is a very clinical test which you just do by making the patient walk as much as he can, as fast as he can, for 6 minutes, or you do a very complex procedure which requires specialized equipment and this thing, which is cycle ergometry. So you do cycling on a special cycle, and you have a mask for which you consume your oxygen consumption and carbon dioxide elimination are measured, and you can sort of see how much oxygen is being consumed and how much carbon dioxide is being produced. And you can also separate whether this problem is cardiac or whether the lungs are not working optimally. So the simplest test and a sort of screening test is a 6-minute walk test, right? If you can walk 1,000 feet, then you're fine. If you can walk less than 200 meters, right, which is about 600 feet. If you walk less than 200 meters, then there is a good chance, then this data is for lung volume reduction surgery. There is your prediction of mortality or complications is quite high. And the good thing about the 6-minute walk test is correlates with the sophisticated measurements like VO2 max, that is peak oxygen, maximum oxygen consumption, and maximum work capacity that you actually generate during a formal cycle ergometry CPAP. Further, if you desaturate by more than 4% during a 6-minute walk test, it tells you you are in not good shape and there is a very high risk of post-operative complications. So the 6-minute walk test is a very nice, simple test which you can do. You need to make the patient walk for 6 minutes as fast as possible and see how much distance he has covered and what is the degree of desaturation that takes place. Like I mentioned, a more formal test is a CPAT using a cycle ergometry. Sometimes you can use a treadmill, but otherwise you use a cycle. And as time goes on, you can increase the resistance against which the person pedals. So that's a dynamic sort of testing, right? So in this, you're exercising, so you can detect oxygen consumption, the maximum, the VO2 max or the VO2 peak. You can also do, you also do correct ECG electrode, so you also get a sort of stress test, right? A cardiac stress test. And different parameters are there. I won't go into great detail, like the oxygen pulse and so on, which help to decide whether cardiac output is increasing adequately, whether your ventilation is increasing adequately, and very importantly, there's a parameter called as anaerobic threshold, which is consumption, when the CO2 production is in excess of the oxygen consumption, and that means that the muscles are now going to get anaerobic because there's not enough supply to the exercising muscle. Okay, so the anaerobic threshold at which this occurs, that is also a very important parameter. Right? So this CPAT gives you a very objective assessment. It differentiates, like I mentioned, respiratory and cardiac conditions, which are causing exercise limitations, and therefore it helps in risk stratification and targeting patients for optimization. So these are the sort of numbers that you're looking at when you're doing CPAT. So if your VO2 max, so its peak oxygen consumption is more than 20 mils per kg, and your anaerobic threshold is more than 12, you're okay. If your Vmax, VO2 max is about 10 to 20 mils per kilo, and anaerobic threshold is 10 to 12, you're at intermediate risk, and you're at really high risk, and you should reconsider doing surgery if your VO2 max is less than 10 ml per kilo, or anaerobic threshold is less than 10 ml per kilo. So these are rough cutoffs, and they actually help you risk stratify. Because, for example, again, I'm not going to go in detail about lung dissection, but there are some patients who do not do, who've got borderline PFTs, who've got borderline lung scans. But then when you do an exercise test, they still meet the targets, right? Then you can probably take them up for surgery. But if they do not meet the targets for exercise stress test, then you probably need to reconsider surgical surgery for these patients. Okay, so now we focused a lot on COPD, and we could focus similarly on asthma. We could say that for asthma, you need to do this. For interstitial lung disease, we need to do that. But this is the score which has been developed, which is called the ARISCAP score, which predicts the risk of post-operative pulmonary complications. This stands for Assessment of Respiratory Risk uh, After Surgery in Catalonia. So this was developed in Barcelona and in Spain, in Catalonia, but it's nicely called the ARISCAP score. It's been shown to work reasonably well. Now, if you see here, the factors which make a difference are age, more than 50, and if you are higher than 80, then you get more points. Okay, a lower SpO2, presence of respiratory infection in the last month, anemia, hemoglobin less than 10, surgical incision, if it's upper abdominal, 15 points, if it's interthoracic, 24 points. So again, high risk for interthoracic. Duration of surgery, if it's less than 2 hours, not a problem, 2 to 3 hours, some problem, more than 3 hours, very much of a problem. Emergency surgery, 8 marks. So if you aggregate the score, if you're low risk if your score is less than 26, intermediate risk if you're 26 to 44, and high risk if you're more than 45. Now, if you notice in this score, presence of COPD, presence of heart failure, presence of asthma, uh, arterial PO2, history of smoking, all of these are not in the score. Whereas we always traditionally think of these as, very high risk, predict high risk. But what the authors say, and which probably makes a lot of sense, is that if the history of smoking is a problem, if COPD is a problem, it will be reflected in some of these things, right? Okay, so so these are actually significant parameters, because all the other parameters that we talked about, COPD, asthma, interstitial lung disease, all those, if they don't have, are not associated with a low SpO2, if there is no infection associated with these complications, then these patients are unlikely to have a problem. In other words, it is not the respiratory diagnosis or smoking by itself that leads to a complication, right? It is the effect of how the lung is at the time of surgery. So in other words, in this article, which is a very nice supplement in anesthesia, which came in 2019 on preoperative optimization, a patient of COPD who's well managed, who has no bronchospasm, with a reasonable oxygen saturation, has not had a recent infection in the last 1 month, this probably behaves similarly to a patient who does not COPD in terms of risk of postoperative pulmonary complications. Okay, so it is therefore important to identify patients whose respiratory system is not well on these simple clinical grounds. So if the saturation is low, if they've had a respiratory infection in the past, if the patient is anemic, and you know that your patient is going to have major upper abdominal or intrathoracic surgery of prolonged duration or emergency surgery, you know that you know to focus on this guy to try and optimize his condition as much as possible. Okay. So for example, our patient with Whipple's, he was 62 years old, so you get 3 points. His saturation was 92%, so he get 8 points of 3 points, 11. He's not had an infection. His hemoglobin is okay, but he's undergoing major upper abdominal surgery. He gets 15, so that's 11 plus 15, 36. And the duration of his surgery is more than 3 hours for a Whipple, so he's got 59 points. This patient comes in as a high risk for post-op pulmonary complications. So, so this is how you can use the ARISCAT score to risk stratify your patients. And then you need to optimize these patients. So there are actually 5 simple approaches, like a 5 steps approach, or 5 components. One is you reduce smoking, stop smoking. Second, you dilate the airways by beta bronchodilators. Loosen secretions by hydration. Remove secretions by chest physiotherapy, postural drainage, whatever it may be, and get them to a bare minimum. Right? If there is infection, you need to treat the infection. And then very importantly, respiratory exercises and measures to motivate and educate the patient, because these things have to continue into the post-op period, and so we'll talk a little more about respiratory exercises a little later on. But these are the essential sort of things that you need to do. How does stopping smoking benefit the patient? So some people say that, stop for 1 or 2 days, I mean, what difference is it going to make? But even if we stop for 1 day, the effects of carbon monoxide, the levels go down, and the effects of nicotine will go away. In 1 week, the airway reactivity reduces significantly, though some people have argued that up to 1 week, if you suddenly stop smoking, patients may actually be more reactive, but it doesn't seem to make a difference to outcomes. Okay. So then the longer you stop smoking, you have reduction in sputum production, reduced wound complications, and full benefit with restoration of mucociliary function, which has been damaged by smoking, takes place about almost 3 months. So if you've got a very, very elective surgery and your patient is very compliant and doesn't smoke for 3 months, you can actually get normal uh, mucociliary function, and you will get the full benefit of stopping smoking. And many people argue, as a public health sort of thing as well, and what we call about behavioral modification, the fact that you're going to do major surgery on a patient may actually give him the stimulus to stop smoking. And they have noticed that many patients actually stop smoking because this was the sort of trigger for them to, stop smoking, or else will have higher rate of complication. They stop smoking and they remain away from smoking. So many people say it is a good time to wean the patient away from smoking. So that's what some people would say. But bottom line is stopping smoking is beneficial and it should be pursued. Bronchodilators work very well because one is, of course, they dilate the respiratory smooth muscle, improve the breathing, and in patients with COPD, because your airway obstruction goes away, your expiratory airflow resistance decreases, hyperinflation is reduced, and the hyper lungs are less hyperinflated, and that improves diaphragmatic and respiratory muscle function, which helps in the postoperative period for coughing and clearing secretions. It also increases the bronchodilators will also improve mucociliary clearance, and the reduced cholinergic transmission will reduce the bronchoria or the secretions and help the patient. So overall, bronchodilators work very well. You need to control infection. So never ever take up a patient who has an active infection, unless of course it's an emergency. And that can include a pneumonia, it can include an exacerbation of COPD, it can include even tuberculosis, which is active and not controlled. Of course, you need to get rid of secretions with just physiotherapy and hydration. Okay. So you can use all sorts of things like saline nebs or acetylcysteine, but these work in some patients, but acetylcysteine can cause allergic problem in some patients. So the simplest way is to make sure the patient is well hydrated, okay? And he's not dry, and so you can do that. So that helps these patients. And of course, if the patient is oxygen dependent, you make sure patients get oxygen. Uh, uh, of course, they are not very good candidates for surgery, but you can make at least nocturnal oxygen may be given to some patients. Steroids were indicated, and if the patient has evidence of heart failure, then diuretics, digitalis, and nowadays there are many more drugs, which I'm sure Vijay Shetty will talk about, which can be used to improve heart function. Steroids should not be given just as a matter of routine, but they should be given in patients who've been on long-term steroids, okay? Who are taking more than 10 milligrams of prednisolone daily, or patients who, or at least for the last 3 months, or those on very high dose inhalation steroids. And there are recommendations for preoperative steroids. These are mainly, firstly, of course, to substitute for the oral or inhaled steroids that they are been taking. Secondly, to maintain the steroid cover in the perioperative period. And very importantly, in patients who've taken long-term steroids to overcome the suppression of the hypothalamic pituitary axis, which may have taken place because of prolonged use of steroids. So if you've been taking, less than 10 milligrams of prednisolone a day, then you don't require additional steroid cover. But if you've been taking more than that, then depending on the nature of surgery, you have to supplement further steroids, right? So if it's minor surgery, 25 of hydrocod, moderate surgery, then 25 milligrams TDS, and major surgery, then 100 milligrams hydrocortisone 3 times a day. So you need to cover for steroids. today we are not just talking of optimization, or we are talking of optimization of the comorbid condition, but the optimization of the comorbidity. In this case, of course, a respiratory comorbidity has to be within the context of what we call as prehabilitation. And rehabilitation means preparing the patient for the operation and of course the subsequent treatment. For example, in cancer, many patients will undergo chemotherapy soon after, within 2 to 3 weeks of the surgery. So they have to be, so whatever we do in the perioperative period, our anesthetic technique, our post-operative techniques have to be good. And even our preoperative preparation has to prepare the patient not only for the surgery, but also for the chemotherapy that the patient is going to receive 2 to 3 weeks after surgery, right? The pre-optimization has to not only help the patient overcome the surgery, but also to return early to a psychologically and a physically healthy state. So prior to his return to intended oncological therapy after cancer surgery. So that's what I said, prepare the patient for chemotherapy or radiotherapy, right? And of course, to make sure that there are no post-operative complications. So all these things, so to prepare the patient so that there are no complications. So rehabilitation not only is to prevent complications, but also to ensure health and wellness and an ability to withstand further therapy that may be required in some of these patients. And therefore, what you need to do is multimodal rehabilitation. So one is nutrition, second is psychological. I'm going to now tell you about exercise and physical activity. So exercise and physical activity is extremely important, to keep up the respiratory muscle function, to build up some some muscle function before the surgery, and if possible, to even continue after surgery. So at least in the preoperative period, you have to prescribe a targeted individual exercise element, and that consists of cardiovascular training as well as resistance or strength training. Now, you may wonder how will an 80-year-old person who's got cancer do all these things, but these things are happening, and people are doing this. Of course, you don't push them to lift 50 pounds and 100 pounds kilo weights, but as much as they can do, but some element of cardiovascular training and some element of resistance training should be there. And of course, you should encourage daily physical activity that is at least 30 minutes per day. Right? Reduce sitting or sedentary time, and to again behavioral change. But that's a sort of long-term sort of. So exercise is now important, and exercise has been shown to improve cancer outcomes in some studies. So there is some evidence to suggest that exercise is preoperative exercise is good because it helps the patient build up strength for surgery and also improves outcomes in some way. You need to have respiratory training, right? So you need to have incentive spirometry, deep breathing, and physiotherapy. So, and the focus is on developing the inspiratory muscles. Very often people, take that fuga and they tell the patient to blow out into the balloon. That is not what we want. We don't want expiratory maneuvers. We want training of inspiratory muscles. So they should be able to do an incentive spirometer, push the ball up as much as possible, 800 ml, 1000 ml. Okay. And if you do all this sort of things, it's definitely been shown to produce. And again, things which we don't pay much attention to, but oral hygiene. We reduce the bacterial load in the mouth, in the oral cavity. It reduces post-op complications. Mobilization, very important, because if you want to prevent post-op complications, you need the patients to be up and about. Elevation at the head of the bed, especially in intubated patients. Right? So all these things need to be done. And all these respiratory maneuvers, exercises, they must start pre-op, both so to be maximally effective at the time of surgery, and also so that patients are able to learn and educate themselves so that they can perform these similar things and they're familiar with these maneuvers in the post-operative period. Inspiratory muscle strength training aims to specifically increase both inspiratory muscle strength and endurance. Okay. Now, there are different ways of doing it. Okay. You can have supervised sessions for about 2 weeks prior to surgery, where they read, and they have special instruments which increase the load of the inspiratory muscles, right? So the spirometer or something will have some valve, and it will have to progressively increase the strength at which they sort of do that. So there are therapists who will do these kind of things. And apart from respiratory muscle exercise, they also want to do overall exercise, right? So preoperative exercise programs are recommended for patients having major surgery, and especially where they are not very fit as maybe as revealed by the 6-minute walk test or the CPET. Now, there are some are supervised programs lasting over 6 to 8 weeks, but that's a bit impractical for patients who are about to undergo surgery, and certainly for urgent surgery like cancer surgery. Okay, but there are also programs of high intensity interval training, and not the same kind of high intensity interval training that athletes do, but high intensity interval training designed for that particular patient. Okay, that can improve fitness in about 2 weeks. So that's a reasonable amount of time. So from the time that the diagnosis is made, the surgeon can refer the patient to an exercise clinic for these sort of things. So, like I said, that if you want to do all these exercises, optimize the patient, then all this. Of course, we need to optimize, but also we need to balance it with the need for surgical intervention, depending on the type of surgery and the type of disease the patient has. Unfortunately, by the time the surgery is fixed and a diagnosis is made, and the surgeon wants to operate quickly, probably because the patient will otherwise go to some other surgeon, there is not much time for optimizing. That is the unfortunate part of this. Therefore, many people argue that surgical care plan should begin as soon as a patient is identified as a surgical candidate. In other words, your clinical pathway for preoperative optimization need to change. So this was a sort of traditional thing, that patient comes to the hospital, goes to the surgeon, finally a decision is made. And once the decision for surgery is made, then he goes to a pre-op clinic. Surgeons never see blood pressure, they don't see reports, they send the patient to a pre-op clinic, right? And that's where the first sort of assessment is done. All starting with blood pressure right down to the other things. And then you stratify, and then you say, oh my God, you're medium risk, you need ICU. And then, or you postpone the surgery. Sorry, boss, you're not fit. Come back after 2 weeks, see a chest physician, see a physician, see a physiotherapist, and so on. So that leads to delays and so on. So what now people say is that, as soon as the decision, uh, not even a decision, as soon as you started thinking about surgery, you should start doing a assessment of the patient, right? For example, in this case, respiratory function of the patient, do a CPET, do a 6-minute walk test. At that stage itself, you stratify as low risk, medium risk. By the time the other investigation and tests are going on, you've already started educating the patient, you've already put him on an exercise program. While he's on an exercise program, he goes to a pre-op checkup clinic. So pre-op checkup clinic, in fact, becomes the semi-final or the final step in assessment, rather than the first step after which all these assessments start. And then you sort of, the rest of your treatment goes according to your risk stratification and how well you've been optimized. So optimization, in order to give optimization a chance, it has to start actually maybe with the referring GP or surgeon well before he actually plans or schedules the surgery, right? So all these things need to be taken out, and so it needs a little bit of culture change, a little bit of thought process change for us to do an optimization. So that's roughly what I had to say. And I know I covered a lot more of general optimization and a little bit more specifically about respiratory optimization. At some stage, I'll be happy to take any questions. Thank you.
Thank you very much, sir, for that wonderful and still a very extensive lecture and extremely to the point to the respiratory optimization. Um, we would like to have a chairperson's remarks. Dr. Balaji, sir.
Yes, it was a very wonderful presentation as usual, Diwatiya sir, and you covered almost all the points. And as we also observe many times, unfortunately, we see the patient at last moment where there is hardly any chance for optimization. But those patients who we can see in early stages, and there is, if you follow this protocol of optimization, definitely the results are remarkably different in those patients. So I think everyone must follow this optimization protocols, and as and when anesthetist should intervene at the earliest, see the patient at the earliest, as sir rightly told. If there are any questions, we can take it.
Yes, Charulata madam, you.
Yeah, I think as usual, Dr. Diwatiya has done a wonderful job. Very, very practical points and very systematic and a stepwise approach. and how to stratify the risk. Everything was covered. So it was a wonderful lecture, as always.
There are no questions. Actually, sir has answered everything. So
Oh.
actually, I just,
Yeah.
sir, wanted to know, we used to give steam inhalations. And as you said that we hydrate the patient so that the patient can, for the mucociliary clearance. So is there any role of steam inhalations along with nebulizations?
Yeah, so it all depends on how you give the steam inhalation. So if like in a hospital ward, that same jar and there's that hookah sort of thing which you give and it goes around from one patient to other, I think that's not a good way of giving steam. It is unregulated temperature. Okay. And steam is nothing but giving water vapor at higher temperature in an attempt to humidify the mucosa. Now, sometimes it may be counterproductive because if it's too hot or you can get burns. But apart from that, the hookah is a source of infection. So if at all the patient is doing stimulation, you should tell them to do it at home, with their own pot and their own this thing,
Personal steam.
at a personal this thing. But as long as you're drinking enough water, as long as your throat is not dry, you're not taking dry oxygen, a little bit of nebulization with water or saline is okay. There's no need to give things like hypertonic saline although a lot of people give it, more often than not, it is a placebo for the doctor rather than something of value for the patient. We feel we are doing something. But the basic principle is don't get too dry. Having said that, there are some patients, COPD or heart failure, who are often on Lasix, so, who are being this thing, but we still need to make sure they're not too dry and they're able to expectorate. The secretions are not thick. Right? So, advice, humidification is extremely important. So, you need to make sure the patient is well hydrated and humidified.
Sir, I wanted to ask you, is there any role of mucolytics?
So, in general, there isn't. But if the secretions are very thick and tenacious, and the patient has trouble being out, you can try mucolytics like an acetylcysteine or mucomist or something like that. There is a small danger of provoking allergic reactions or, with these sort of drugs. So if you can, the problem is everyone straight away prescribes mucolytics, but maybe just bronchodilators and humidification can sometimes do the trick. If it doesn't work, then you can definitely try all these things. But again, they are not always necessary, and there is always a small risk attached to this.
So sometimes the mucolytics will increase the cough becomes too troublesome.
Yes, so it irritates. In fact, they
Yes.
irritate the mucosa, so they cough a little more. So
Yes.
of course we think expectoration हो रहा है, खांसी आ रही है, निकाल दो सब अच्छा निकल रहा है, but it may, like I said, sometimes be counterproductive.
There is a question in a known asthmatic but not symptomatic now, should pre-op nebulization be given?
So whatever the patient is taking for chronic control should be given. If the patient has not taken anything, I still think it's not a bad idea to give, formoterol or salbutamol, because especially if you're going to intubate the patient or something, then you might want to keep the bronchodilator on. If you're going to give a spinal or you're going to give a regional anesthetic, maybe not. Keep it standby.
And the drug of choice, sir,
But if the
levosalbutamol.
patient is taking something, he must continue to take it. So nowadays, a lot of people will get, combination of formoterol and a steroid, glutinoside, like that's Foracort or something like that. So they should take that.
Foracort,
Yeah,
yes.
yeah.
Foracort
So that's
means.
a long-acting beta-2 agonist, but also acts pretty fast. So that's a good agent. If there is active wheezing which occurs during the periodic period, then things like salbutamol or levosalbutamol are okay. You can also add many smokers will also be prescribed ipratropium, that's Ipravent, or Duolin, which is a combination of salbutamol and ipratropium 4 times a day. So if they have got excessive secretions, then again ipratropium can be given. Or even glycopyrrolate nebs are available now.
So, can I ask a question, sir?
Yes, ma'am.
Yes. So excellent lecture. And so there are many patients who cannot stop smoking. And they find it very difficult. And then the perioperative risk increases. So anything special we should do in these kind of patients where we are going to secure the airway?
No, so then you have to make sure that the patient is optimized in all other ways. Even if the patient has not been able to stop smoking, make sure his patient is optimized in all other ways. Uh, and if you feel that there is a risk of hyperreactivity, you can give us inhaled steroid and bronchodilator to these patients. Patients who have continued to smoke throughout, till the day before the operation can sometimes have more delirium in the post-op period. And maybe even it will appear encephalopathic or withdrawal sort of thing. In some of these patients at a nicotine patch.
Thank you.
Dr. Shetty has asked any specific advice for obese patients.
Well, I know you can't ask them to lose weight and come for surgery. But again, they need to have all those sort of respiratory, inspiratory maneuvers to be done as much as possible. Of course, obstructive sleep apnea is a problem is always on the cards for obese patients. They are so they should have their CPAP or whatever. And unfortunately, many of them may not be having CPAP. So maybe we can give them CPAP in the preoperative and definitely in the postoperative period. Because if they've got obstructive sleep apnea and they're giving them narcotics or something, especially for pain management, they may sort of get these things. So they may require CPAP or even BiPAP to some patient or some of these patients. And all these high risk patients will, especially obese patients, they have much more atelectasis, okay, during surgery, especially during upper abdominal or even laparoscopic surgery. So these patients should be treated as all high risk. The same sort of things need to be done. They all will most likely need ICU admission. So, it's nice to have a talk with the respiratory physician, the bariatric endocrine person, because they'll have diabetes and all those sort of things as well. And of course, the ICU team should, I think that Vijay just asked this, that should involve
Yes.
the ICU team. So yes, you should definitely involve the ICU team when you're taking up such high risk patients.
Any pre-op cutoff for PaCO2, sir, for preoperative BiPAP therapy, something like that?
So usually these are the things which will be determined by the chest physicians, whether they require home oxygen at night or they require BiPAP. But in general, it is not so much the CO2 as the pH. So if the patient has COPD and he's CO2 retainer, he is very likely to have a PCD of 50 or 55 or maybe even 60. But as long as the pH is about 7.35, I think he's okay. If the pH is below 7.3, then there's a problem and he actually needs active BiPAP
Acute.
in acutely sort of, and maybe while preparing and taking care of his. If his pH is 7.3, that means he probably needs his COPD is not optimized and he needs further optimization. Yeah, so it's a good question, but my answer to that would be focus. Of course, the CO2 is worth looking at, but I'll focus on the pH because that is the primary sort of target which you should focus.
There is a question: should we give injection deriphyllin as pre-medication if cough is there in asthmatics?
I'm not sure of that at all. I personally have not used deriphyllin for the last 15 years. But if it makes you feel good, you give it. I don't know how much benefit it will do for the patient. There are some new molecules like moxophylline and so on are there, but by and large, I mean, I know it's easier to give an injection than to nebulize, but the best form is to nebulize or to give a meter dose inhaler. Now, even intraop, many of us don't like to give meter dose inhaler or nebulization intraop if there's spasm or just pre-op. But you can do it because you get adapters nowadays which fit into the endocrine tube and you can give the MDIs and they are far more efficacious than injection deriphyllin or aminophylline or whatever
Aminophylline.
those sort of
What
things.
I was going to ask, that aminophylline less and less people are preferring because it causes dangerous arrhythmias, and we have safer drugs available. So
Yeah.
the role of aminophylline as well as deriphyllin is
Yes.
reducing. Should we be involving an intensivist too in high-risk respiratory patients, Dr. Shetty?
Yes, definitely. Especially if you're going to move them to the ICU, they must be in the picture. And many of these will be moved to the ICU. Right? Again, it depends on what is your ICU. If your ICU takes only ventilated, then if you think you're going to ventilate them electively, definitely you should involve the ICU team. If you have a problem, obviously you're going to involve the ICU. But it's always nice to have a group of doctors involved in the sort of what multidisciplinary care of the patient.
There is a question: if you are planning to use atracurium only, can we start antihistaminic preoperatively?
Well, why do you only want to use atracurium? There are drugs. Can you use atracurium? Can you use bacteronium? Can you use rocuronium? I'm not sure. I've not actually come across any article which uses or any this thing with actually it's a good thought that whether to give an antihistaminic to prevent the effects of histamine release with atropine. I presume that's what you're asking, but I don't. I think it's safest that if you're worried about histamine release, just don't use atropine. There are enough alternatives around.
I think there are no more questions.
There is one more question.
Yes.
Can we use steroid pre-op if patient has cough, cold, or URTI, upper respiratory tract infection?
No, firstly, again, my answer is restricted to adults, not children. But if the patient has cough, cold, URTI, either you go ahead with whatever risk it is, or don't do the case, but don't give a steroid. It's not going to help at all. In fact, you might convert a simple cough, cold into a pneumonia.
So, are there any more questions?
I think, in general, I think if the patient has cough, cold, and he has a fever, I think you should try and avoid doing these cases unless it's really necessary. And really necessary doesn't mean the surgeon is going on leave tomorrow, so you need to do it today. Right? So, I mean,
Like if it's an
in general,
emergency
if there's an
case,
active infection, we should not be doing cases. Because today, a cough and cold can be something as simple as a small minor viral infection. It could be something brewing like a H1N1, or something. Of course, COVID is largely not there, but there was a time when if patients did even this much, you would bug the patient from the hospital. So we don't have to be as careful, but I don't think we can we can't ignore these sort of things.
so any URTI which has fever, preferably you should postpone if it's an emergency case. Yes.
Preferably avoid doing this.
Yes. Um, so let us move ahead with the next lecture.
Yes.
Thank you very much, sir. And sir has to move for important meeting. So sir will be joining us, I hope, after the meeting. Divatia, sir.
Give me a call, and if I can get away for some time, I will definitely join. Again, I'm sorry for having to run away like this, but
No, fine.
and thanks for accommodating me.
Thank you, sir. Thank you.
Thank you, sir.
Thank you, sir.
Yeah.
So I request Dr. Saurabh to introduce Dr. Vijay Shetty, sir.
After this comprehensive discussion on cardiovascular system optimization, we have Dr. Vijay Shetty, another well-known speaker and wonderful anesthesiologist, to speak on preoperative optimization of cardiovascular system. He is a director of anesthesia services, Fortis Hospital, Mulund, Mumbai. He is the organizer of very popular MASCON, organizing secretary of IACTACON 2020 held in Goa. He is presently executive member of IACTA, He's teacher for DNB and fellowships in cardiac anesthesia of IACTA. He has multiple recognitions, the best part, for the work in the field of brain dead organ donation, and a team member who have done more than 100 heart transplants, multiple publications. Dr. Vijay Shetty. Welcome, sir.
Thank you, Saurabh. Thank you for that kind introduction. Saurabh is an old friend, so he was little more luxurious in this introduction. And thank you, Dr. Naitha Madam and Dr. All the SAMS team to giving me this opportunity. I'll try to cover up some part about preoperative cardiac optimization, and I'm very happy that Dr. Divatia spoke before me, because it also meant that some of the things I realize and we know now that is quite it's quite similar in both of these optimizations, is that we are looking at the patient in toto, but since we are cardiac people, respiratory people, intensivists, we're trying to integrate, rather focus on one thing. But what we really need to do is to integrate everything else into one. So into one common purpose, that is to keep the patient safe. Is this visible, Saurabh? We're okay?
Yes, sir, very much.
So I bring you greetings from Fortis Hospital. So now, okay. So what are we trying to do here is that first, the first definition I want you to understand is, or at least when we communicate, and I always start my talk with this, as NS, there is young people in the crowd also. And when we communicate, we need to each other or with our contemporary in other disciplines. We need to hold on to some certain terms. So one of the terms that comes across in guidelines is major adverse cardiovascular events. And this is important because what the statistics showed, and we're very much certain that it is much higher than this, that if you're a 45-year-old person and older and undergoing a non-cardiac surgery, the incidence of major adverse cardiovascular events after non-cardiac surgery is about 3%. That means if all of us together have operated 100 patients who are above 45, 3 of them will have a major adverse cardiac event. That is today's statistic. And this represents a major source of morbidity and mortality. And the classic 3-point definition is any patient who gets a non-fatal myocardial infarction, a non-fatal stroke, or has a cardiovascular death. He dies because of CVS, or because he has got a non-fatal. He doesn't die, but then he has got a MI or he has got a fatal stroke. And if you add the hospitalization for congestive heart failure, or him being readmitted or being hospitalized for unstable angina, the incidence is much more. So what is our role? Like Dr. Jiggy very clearly pointed out, we come somewhere in the intersection as a patient goes through a high-risk zone. And if we trivialize or jeopardize this process, then what happens is that the patient is going to lose the last person who was going to keep him or her safe during this major work. And therefore, our job as optimization of cardiac status or cardiac factors in the pre-op period, we need to do this because we don't want to complicate the patient's perioperative course. Peri means before, intra, and post. Therefore, that we will be very popular with the intensivists and the administrators if we ensure that the patient spends the least amount of time in the hospital. And the best way to do it is by ensuring that the patient doesn't develop a major adverse cardiovascular event. And as you can see, if patient has got any other comorbid condition, whether it is heart, kidney, ultimately it is a cardiac risk. It's the heart that finally gives, and that is why the patient remains in the hospital for longer. So we have to really ask whether cardiac risk reduction is possible, or we just embrace the risk that comes along. And I know that many of the listeners might be senior anesthetists who might be done multiple of these cases over and over about, and just by the precision and the care and the interest that they did that anesthesia with, ensure that the patient went across this high risk zone with minimal discomfort. And that's why I have a lot of respect for the people working outside major corporates and all, because their role is even more difficult than what probably I have to do in my hospital. So what we are basically trying to do is to prevent cardiac ischemia, infarct, worsening of existing cardiac conditions, and all this while we want to maintain the hemodynamic stability, keeping in mind what the surgeon requires to get this surgery done. And we do this also because it gives us some points to talk to the patient. Otherwise, it is just a question of doing a documentation and sending him off. What do we discuss the patient? We discuss with the patient and the family and our surgeon and our team about the risk that we perceive in this patient and the strategies. Therefore, our goal is not only to ensure a good, smooth process, but also show that we have taken the we have done the due diligence, we have taken the care, we discussed, documented the risk, and we discussed the strategies also. So even if the things were to go bad, we already have a plan, and this plan is non-debatable. Like even if this was to go to any other hospital, they would have had the same plan, and that ensures that you've done the proper process. So there are multiple guidelines. One of them is this 2022 is one of the recent guidelines of the European Society. And this they in this cartoon they have very beautifully said what are the things that we undergo as the patient is undergoing a surgery, a non-cardiac surgery. You see, he's got comes with multiple comorbidities. There is a bleeding and a thrombotic risk because the patient will be on multiple drugs. One for prevention of thrombosis, and second, the treatment of the antithrombotic drug itself will lead to some bleeding. And there's a hemodynamic or arrhythmia risk because this, as you know, the heart is a wonderful organ, but then you have, as it starts failing, it leads to multiple problems of failure and arrhythmias. At the same time, any of these problems can lead to hypoxia, hypotensive or hypertensive episodes. It can be hypovolemia. All this can interact, leading to a very complex concomitant of problems which the anesthetist sees on a daily basis. And while doing this, we try to assess whether the patient has got a surgery which is a high risk, low risk, or intermediate risk. For example, now the most popular surgery is the cataract surgery, and you know why? Because the patient can't see the Netflix now. So this is the one of the most common popular surgeries. So we might be this is a very low key for us, but it actually for the patient is a very high end surgery. Or the patient might be coming for intrathoracic surgery, which we know, as we discussed now, is a very, very high risk proposition. Or the patient might come for a peripheral surgery like an hernia. But don't get fooled by this, because the cataract can go bad, or even something like this hernia can be a very difficult proposition. For example, this is only yesterday's patient. This is an 81-year-old with such a big hernia. He's come to us. He's got, like Madam said, all Sarvagun. He has everything under the sun. He's recurrent heart failure. For the last 1.5 years, he's visiting the surgeon, anesthetist. They send him to the cardiologist. Cardiologist gives fitness. Okay, he can go with high risk. And within 2 days, he gets admitted with the heart failure into the hospital. He's got large hernia, bilateral. One is very near obstruction. It is not amenable for under local anesthesia. He's got all the comorbid, like I said. He's got CKD, CLD, EF of, as you can see, he was admitted. This is the last admission only 3 weeks back. Acute left ventricular failure, and his a basic diagnosis of a heart failure with a reduced ejection fraction, HFrEF, and he's not on any dialysis. So he's an 81-year-old. You can see he's troubled, and he's this is his ECG again. He's got multiple ventricular ectopics and atrial ectopics as well. So this is the patient that took him in, and I'll just tell you what happened in the OT. This is the arterial line we put for these high-risk patients. No central line was put because it was still a peripheral surgery, like I said. And what you see classically in this patient, in the elderly patient, is a high systolic BP, a low diastolic BP of 37, and high pulse pressure. The importance of this I'll try and explain to you maybe a little later. And you can see the NIBP is not showing the correct BP, and this is the invasive BP, which is correctly reflecting the high pulse pressure that you come to expect in this, and a low diastolic pressure. And we gave him a GA with BIS. He kept on having the VPCs, and so the surgeon, it was well anesthetized, but as soon as this knife goes in, you can see the BIS going on there around 40. With a decent BIS also, his BP has jumped, and still the NIBP is not showing the proper pressure. So you're dealing with these kind of patients, and how do we optimize him is the query. And this patient had a good outcome at the end after a 2.5 3 hour surgery under GA. He had a good outcome, and then we also sent him to the ICU because we needed to monitor him. This is this BP at the end. Now, this is a typical high risk patient who we come with multiple comorbidities, and we need to know that how do we optimize him. The first real preparation, actually, I would like to say, is the preparation of the anesthetist. That I identify this patient. I take it upon myself to identify a at risk patient so that I have time to optimize that patient. So he undergoes the surgery with the least amount of risk. Of course, risk won't go away, but there's a great chance that he or she will do well. Now, if that responsibility is accepted by me, I will do a good job at it. Otherwise, I'll go by that my last 9 patients did very well, the similar conditions. The 10th one will give you a problem. And I think that is a ratio that we cannot accept. And the first thing first is that we should start is to listen to what the patient has to say. That means we'll have to give him time. Now, this is a very good article or the guidelines, which practical guidelines has come out, and I request, like I have been reading the guidelines in 1998. Every time they come out, we have some meetings and we discuss, and it keeps on brushing. And I'm sure that most of it, what I'm going to say today, is a reflection of what has been developed over the last few years, and you would also see the sense of repetition. That is not a problem at all, because it will try to make you the person that I want you to. I am thinking that all of us should become. So this is the 2024, the latest guideline. So why is it important? Because we are trying to find out if a patient is at risk. I don't want to waste my energy on patient who may not be at risk. And the second, and exactly what Dr. Jiggy said, I can't I can't push everybody to an investigation. At the same time, I want to make sure that while not having an over treatment or an over diagnosis, I still am selecting the selected patient for the right investigation. So this was how we were at Young. We saw a very high risk patient, and we said, Excel, this is my chance to do well. And those things those times have gone now, because I am expected to give the care that everybody else would have given with the same kind of resources. And this bridge crossing is now not so easy, because you find some of them go across, and even the same patient will not cross the same bridge again, because the conditions would have changed. So we would really need to be aware of that. Now let's talk about the anticipate timing. This is another feature that we should be, if a patient comes to us, we should be having absolutely, we should be very objective about what is the anticipated timing of the surgery. Is it an emergency, meaning the patient would lose his life or limb if not operated within the next 2 hours? Is it urgent? That means that it is a threat to life and limb. However, we have a few hours, maybe up to even up to a day, maybe, to allow some interventions to be done. Is it time sensitive? Meaning it can be delayed for up to 3 months for a proper evaluation and optimization, and this delay would not negatively affect the surgical or the clinical outcomes. Elective is, as we know, that it is okay if the surgery is not done even. Why do we care? Because I just give an example of all these things. Emergency means if there is a occluded chronic, it's a transection of a humeral artery. It's a traumatic transection. He comes within 20 minutes to the OT, and if you don't operate, of course, he's going to lose this limb. Urgent is the same artery if it is chronically occluded, but now has ischemic symptoms, but limb is warm, and now say the blood sugar is around 800. We don't have to rush him to the OT in the next half an hour. We can spend time to optimize the sugar and then take him up. Time sensitive, it's a carcinoma stomach detected during this patient of ours who was going for a CABG. During routine workup for the CABG, detected there is a something in the tummy, and and the oncologist says that the endoscopy looks like it is and the features don't look like it's going to breach the serosa soon, and it's not a bleeding risk. So we could probably go ahead with the CABG and get him on the table after a month, or within a month, or even 8 weeks or so. So this kind of scenarios also we have faced. Elective is a unilateral TKR with OSA. He had angiography done, but angioplasty was advised but not done. So of course, we're not going to rush him to the OT. So these are the time that we have to decide whether the patient is an emergency surgery, an urgent surgery, a time-sensitive surgery where we can wait for up to 3 months, or is an elective patient. Okay, so these are the scenarios that we will be talking about whenever a patient comes to us. Now, the next thing that you have to discuss with your colleagues and the surgeon and the patient is, what is my risk of the operation? Now, when you talk about this, all these things are important, because you need to know is there a need to optimize the patient at all? Or if can I go ahead? Like I said, is there really a chance of reducing the cardiac risk? So this is the RCRI which came to about on 2008. And so I really like this score, and I still follow this out, and this still comes across multiple papers. So this is the question that you ask. Is there a history of coronary disease? Is there a history of heart failure? Does the patient have cerebrovascular disease or a stroke or something like that? What about the surgery? Sorry, does he have a diabetes mellitus, or does he have a creatinine which is more than that? It comes around 2 milligram%, or creatinine more than 2. Is the surgery high risk? Means is it a vascular surgery of or a suprainguinal vascular surgery, or is it intrathoracic or interperitoneal or neurosurgery? Those call for a high risk surgery. So you give 1 point for each, and then you find that if there is up to 1 point, what you realize is that this 1 point is important. Why? Because we are looking at the risk. You please note also that somebody's got no risk out of this doesn't mean that his ability to generate a major cardiac event is zero. So there is not a zero risk. There is still a risk of 0.4. And having one of these factors will increase double the risk to about 0.9. It is still less than 1. And as the number of risk factors go up, you find that the risk of developing a major adverse cardiac event goes even up to more than 11% for factors more than 3. So this is a simple score. This we can incorporate into our anesthesia charts as well, just to have an idea. Also, it helps the manager like me to do a good job, because if I see there are more risk factors, I can also think of posting the senior person who can also do a focused job, and his experience and skills will be better served. So who's a high risk is that anybody who's got a RCRI of more than 1, meaning having more than 1 risk factors will be somebody who's got a higher risk. So this is the patient who's got a high risk, and we can identify this patient as high risk and therefore concentrate on him. So the low risk is somebody who's got a major adverse cardiac event less than 1% of that. That means somebody's got one or less than one factors of this RCRI. And elevated means he's got a risk of major adverse cardiac events more than 1%. So there are apparatus or what do you call apps available which can do it for you. For example, this patient who's got a high risk surgery, who's got a past history of stroke, and who's got a creatinine more than 2. He's got 3 risk factors. So you can very clearly tell the patient also that you've got 11% risk of a major cardiac event compared to this patient who's got only a risk of who's got only a insulin dependent diabetes. He's got 1. So his risk for cardiac major adverse cardiac event is less than 1%. So he doesn't go into the high risk category. So this is a very important RCA calculator. If you add this functional capacity to it, just like in Dr. Jigi's lecture, if you're paying attention, you would realize that adding the ABG with less than 50% fall in the PFT parameters makes it more powerful. Similarly, with RCI calculator, if you also use a functional capacity, it significantly improves its predictive power. Now, there are a number of other calculators which you can use, but for example, some of them use whether the patient is has sepsis. The ASA, which is our favorite evaluating tool, it also is there included in many of this National Surgical Quality Improvement Project, NASQIP calculators and so on. But I don't like them because if you ask the patient so many questions, you will be very unpopular and you can't finish off lot of things in the given time that you have. So we can just ask them for functional capacity, and I have a simple question: is are you able to climb 1 or 2 flights of stairs? And if the answer is yes, that is pretty much the patient comes walking without feeling distress. I think it is okay for me. So if you have to ask them whether you play badminton and all, and they say yes, then I don't think anything else matters. The functional capacity of the patient is important because, as per the recommendation, we have to have something like the Duke Activity Status Index, which actually doesn't fit to our set of patients. So simpler questions can be reformed by us to assess that the patient has got enough. Why is the cutoff of 4 meds important? Because 1 met is what a 70 kg person at rest would need. That means just to stay alive, he'll need that. And as you increase the capacity of work, you also understand that his cardiopulmonary system is adequately furnished to do that 4 mets plus of work, which gives him a fillip. That means that he'll be able to tolerate a major surgery. Other thing, frailty, Dr. Jigis already talked about. There are a number of things, number of phenotypes that we have to, number of studies or apps that are available to tell us about if the patient is frail, especially borderline patients undergoing a major surgery. You have one, you can assess that he is frail, he or she is frail, and also you can see if that can be reversed. This is one of our patients on the this lady who was there, one of our patients who came for a peripheral surgery, but the same patient would come for a major surgery. I would certainly be worried about giving this patient any kind of anesthesia. Now this is a practical thing that the NT-proBNP or the enzymes that we can measure, because they are now available as just like our ABGs. They are available in our ERs or in our ICUs, and just putting a drop of blood, it will tell you what the NT-proBNP. So if you're wanting to detect a myocardial injury or cardiac wall stress, this study has suggested, one on the left, that if the concentration more than 100 picogram per ml, they're independently associated with all cause models. That means again you get a idea that how I need to optimize this patient. Whereas this other study of 3,000 patients said, okay, it is showing an increased all cause mortality, but the same kind of prediction we could have done just by using an RCRI and a functional status, which is what I said, that using a 6-point score along with the functional status, you are able to predict the same thing. So you don't have to go for a NT-proBNP for detecting myocardial injury and quantifying wall stress. So that is what this works. What about left ventricular function? This you get as a part of the echo. And if an recent echo or even something, you see the patient, you decide that I want to go for an echo and send this echo, you should be very sure, why am I sending this patient for the echo? Because I detected a dyspnea. I saw that the patient is breathless. He's got a history of heart failure, but now he's got worsening dyspnea. There's another category. If I have findings of heart failure like edema, I see his distress, I see elevated JVP, I know that I need to find out what is happening. Okay, I know that he was a low EF person, but now he's got new symptoms. Because why we need to detect is because somebody who's got a severely reduced EF, less than 30%, is an independent predictor for 30-day mortality, with whatever surgery class you goes into. Along with the other factors which you got similar propensity is something like somebody's got a low hemoglobin, or somebody undergoes a high-risk surgery, all of them will have these are independent predictors for a 30-day mortality. That's why having a low ejection fraction is certainly something that should be detected. So this, I just want one point to be made. This is a study which is done some time back, but what they found is that out of these many procedures, they found that 18% were performed in patients with heart failure and 34% were performed in patients with coronary artery disease. And guess what? The patient with heart failure had 63% greater mortality and 51% greater 30-day all-cause mortality. What does it mean? That all the professional guidelines till recently were always pointing or discussing about ischemic heart disease or coronary heart disease than heart failure. And with the greater longevity that we have now, we find that elderly patients with heart failure are not uncommon, and they simply pass under the radar and they come to your table because we try to. I'll present a case like this if possible at the end, and therefore our aim should be to pick up these patients in heart failure. And therefore, the another reason why you have to talk to the patient, understand the symptoms, and then assess the echos again to find out and do the BNPs also to find out whether the patient has got actually is in a incipient heart failure or active heart dysfunction. Right ventricular assessment is something again which is becoming very, very popular now. Don't forget to assess the right ventricle for patients who got valvular lesions like MR, mitral regurgitation or tricuspid regurgitation, because ultimately it will influence the RV. Don't forget to look at the right ventricle for patients who's got pulmonary hypertension from any cause, because high morbidity and mortality associated with failing right ventricle. Even Dr. Balaji will agree that our most difficult patients in cardiac surgery, cardiac anesthesia, are ones who have RV failure and who come with a very high double figure CVP of 20 and all. Because this patient, no matter what you do, they always have a bad outcome. These are some of the pictures you can see here. A simpler, like once you start doing the focus, I'll talk about that also. If you find the RV which is coming towards the LV size, and in this case, as you can see, the RV size is more than the LV size. This RV is a portent of bad outcome. Okay, so having a big dilated RV or RV which is as equal, so this progressive dilatation of the RV is what happens, and that leads to severe TR, back pressure changes, kidney failure, liver failure, ascites, and so on and so forth. Now the stress testing. So there was a time when anesthetists were very fond of sending the patient to the stress testing, thinking that they would be safe. So my take on that is this: that no investigation is going to give you a shroud of safety. It will only show that you did some things to assess him. But actually, this way you will be actually missing a lot of patients in whom you nearly had to concentrate on whether stress test is required or no. So what is the stress test trying to do is that you're going to make him run on a bike or on a treadmill, or give him drugs which are going to temporarily increase it. And you're going to see at this point of stress, is his heart able to take it? So you're going to say, will the surgery procedure induce MI? And when you ask this question, you also have to say, if the stress test comes positive, is there a possibility of further intervention? Meaning, what's the next intervention? You'll have to do angiogram, and then you'll have to do a plasty or a surgery. Now, if the surgery is something that the patient doesn't wants to get it done with, he's not interested in doing any further cardiac workup. That pain of that procedure of the fractured spine, or the pain of the hip, or the onco lesion that is going to come will be too much of a problem for him to deal with currently, and he is not interested in doing any. So having a stress test is only going to tell you that there is an inducible ischemia or no. And that, by the way, is also, will a negative stress test mean that the risk of MI is zero? So stress test, again, the purpose is to find out the inducible. So you can consider it when there is an elevated risk surgery. The patients can undergo a high risk surgery of the, not the moderate risk, but a high risk surgery. At the same time, for that high risk surgery, you cannot assess the functional status, because your important capacity of assessing the functional status of the patient is not known, because the patient has now severe osteoarthritis and he is on the bed and not moving around too much. So for that, those kind of patients, it might be this patient might be a very good access tool. Or if your risk tool like RCRI is showing elevated cardiac risk for perioperative cardiac event, that RCI score is more than 11, more than 3 points positive, and you're not able to assess the functional capacity, these patients can undergo. So you're not able to assess the functional capacity, and he's got a high risk surgery, or he's got a high risk of developing a major adverse cardiac event. These patients who undergo also that time, I remember a couple of times that these patients who are not supposed to have a cardiac got deferred. For example, somebody with the acute coronary syndrome had a decompensated, somebody with the severe or symptomatic, even asymptomatic aortic stenosis. Now you send him on a treadmill, he will develop a symptoms there. Patient who had underlying arrhythmias, patient who had a severe uncontrolled hypertension. Now these patients cannot undergo a stress test. And a good cardiologist will send you back with a reminder, please don't send this patient, he's not yet or somebody who's. The other thing about stress test is that I had patients who had very well controlled beta blockers, and you send them for a dobutamine stress. And now the first thing the cardiologist will do for me to elicit the heart rate and the BP rise, I'll have to stop the beta blocker. In doing that, you have made the patient unsafe from what he was safely undergoing. You would have taken him in to the OT with the beta blocker going on, given him a good outcome, because all our safety drugs, safer drugs of anesthesia now are there too, and you have got better monitoring now to predict what is going to happen. So with that, really it is very important that you know why you are sending the patient to the stress test. For example, the dobutamine stress echo has a negative predictive value, meaning if it is saying that your heart is okay, there is still a 10% chance that it might not be okay. And a positive predictive value, meaning it is showing that there are changes, and the patient, none of those patients who undergo surgery with a positive dobutamine stress test might have any cardiac event at all. So that is the kind of leeway that we are having with these kind of stress tests. The other thing I want to also tell, how many times you have seen that the dobutamine stress was negative a few months back and the patient comes for a cardiac surgery? It's not uncommon at all. The patient comes with a triple vessel disease or a left main disease, even with a somebody had said that the stress test was negative only a few months back. So about the coronary angiogram, this again I'll not talk much because I just want to tell you about this study which is done, which is on, again 2004, the CARP study we should call it. 510 patients for vascular surgery, 50 got CABG. They had underlying lesions also, coronary lesions. They underwent a CABG and then a vascular surgery. Other 50% just straight away went for vascular surgery. What they found that the post-op MI and mortality statistic rates at 3 years were similar, meaning doing a CABG did not give any additional protection for the mortality benefit for this group of patients. And for this highest risk of surgery, if there was no mortality benefit, the authors sort of said that even for other groups, there is no point in subjecting patients with underlying coronary disease for a surgery, for a CABG, because the long-term mortality statistic would remain the same. So the goal of perioperative ischemia testing is not to diagnose undiagnosed coronary disease. That is the job of the cardiologist. We want to identify patients who are so sick or who are so on the brink, like for example, a significant left main disease or a severe multiple disease with a problematic EF, where we need to be revascularizing them just to keep them alive. That means somebody who would have otherwise undergone a CAG should undergo a CAG. Somebody who would have otherwise undergone a stress test should undergo a stress test. This slide I just said because a lot of us have now started doing focus, and this I've been saying for so many years that anesthetists should become very good at doing a transthoracic echo. And now even the guidelines are sort of supporting it, saying that focus limited standard cardiac views can be used to closely identify pathology in the setting of human. Suppose you get a patient for emergency and you don't know what is happening. At least you can put the focus. Now this guideline from the ACC AHA. You know that they will not be very encouraging about letting this skill go out of their hands. So it is sort of given as a by state, not even as a guideline, but it is one of the important messages, one of the top 9 messages it is come in this focus. A limited cardiac use is used to identify pathology in setting of human cerebral. It can use in the perioperative period, but I am saying very clearly that you have to get into using it in the preoperative period and getting used to it. Just the purpose of doing it, the process of doing it itself will remove 90% of the obstacles and save these images. And in case you find something, you can ask for a formal TT scan. So this is not a part of the guideline, but it is very clearly said that you should go for it and become good at it in the intraoperative period and the perioperative period. What are the drugs? The statins, please don't stop any statins that are there. I think everybody knows this part. In fact, there may be a role of statin re-intensification. That is, in a very sick patient, you might even be better off increasing the statin dose, but we do it under the cardiology cover only. And initiation of statins in the pre-op, should it be done? It should be done, yes, in patients whom otherwise would have qualified for the statin therapy based on the atherosclerotic coronary disease or a 10-year risk profile. So we should definitely, somebody is posted for elective non-cardiac surgery and has got time in his hands, we could definitely look at it. Because the one thing, just for the beta blockers, statins are not a very easy drug to get what you call used to. They have their own risk profile, uh, peripheral symptoms that they give rise, and in the perioperative period, that might not be a good thing for the patient to develop any muscle pains and kidney issues and so on. As far as as far as the beta blockers are concerned, we know very clearly now, you don't stop any beta blocker that is going on. Don't stop any beta blocker that is going on. At the same time, however much ever you are a big fan of beta blocker, don't start it on the day prior or on the day of the surgery, because that leads to a poorer outcome. You may reduce the cardiac risk by some, but you're going to have a higher risk of a stroke. If there is a need for starting beta blocker, you want to start it at least 7 days prior. It should be started, and it is indicated to start at least 7 days prior for getting the patient to use to that beta blocker, and then subject the patient to the non-cardiac surgery. So you can see this harm, this red one, the harm. There is no in the patient undergoing NCS, no immediate need for beta blockers. Beta blockers should not be initiated on the day of surgery due to increased risk of post-operative mortality. What about this renin-angiotensin RAS drugs? A lot of these drugs are available in the market now, and very commonly they will come with these renin-angiotensin mechanism drugs. So so should you continue the RAS in the pre-op? I am somebody who actually continues or at least gives half a dose. But in the pre-op, there is a group of a lot of people say no, because if you have to discontinue in in patients, you can discontinue in patients who have got controlled BP, and they've got elevated cardiac, non-cardiac risk, meaning that in the risk score, it's an elevated risk for major cardiac events. So you want to avoid hypotension in them. Therefore, you discontinue the drug. There's another group which says, no, you have to continue that in the post-op, because these drugs were exactly started for this mechanism of controlling his symptoms of heart failure, especially with the reduced ejection fraction. And in this, when he goes for surgery, when actually, like I say, his was the maximum, that most need for the heart was there for being protected. You have denied him that, and therefore continuation may be desirable. So if you have if a pro and con, then probably you could give a half dose, or just be sure that your patient has got heart failure. That is the indication for his RAS. Then probably it will be a good way to continue. This is a 2A guide, 2A recommendation, whereas so a continuing is a 2B recommendation. Okay, so we have to think about the real focus is that this drugs help preventing MI, stroke, heart failure, and decline in kidney function for the patients in his life till come to the surgery. And stopping it will help us avoid the hypotension that is imminent for these patients. Of course, then we need to stop it. However, if it is a patient in whom it has been started for a heart failure, then we have to give it a thought about discontinuing it. And you'll be happy to note that this debate is not only for our field, but even the field of nephrology, the same stopping or non-stopping of this is going, because continuing RAS will give him a better cardiovascular mortality rates, better BP control, and you need not use drugs which have not been proven. Same thing for calcium channel blockers, like we have this non-dihydropyridines, verapamil. They are mostly getting started for arrhythmia and angina, while the dihydropyridines get started for as antihypertensives and for angina. So based on the indication, again, you can decide the same way that you do for the, you can, most of them be already continuing. And if there is a very much precipitous need, cause that hypertension may occur or bleeding might occur, some patients might get a half dose or might be withheld. Now, this SGL2, we have to watch out for. This is a drug which, this week only now, my medical person or endocrinologist, we are sitting together to formulate guidelines as to how to prevent this drug from reaching the OT. Because these drugs now are commonly used for renal failure, are used for obesity, for diabetes, in general health. The off-label uses are also there for this. In heart failure, they're used. So they come for multiple forms and multiple varieties. And what happens is that if they're not stopped in time because of the prolonged surgical stress, prolonged fasting, they will lead to euglycemic diabetic ketoacidosis. And this is what is known as, they have formulated a term called SAPCA. This is SGL2 associated perioperative ketoacidosis. And this is something that we should be very wary about. And the current guidelines is to stop these drugs at least 3 days before. And this drugs which is stopped at least 4 days before is not available as far as I know in India. So at least 3 days before, all the SGL2 drugs have to be stopped. And the important thing that we can do as preoperative physician is that if it comes for elective surgery and it has been stopped, or it has not been stopped adequately, one of the things that you can predict what is happening, what is going to happen is that if it is stopped for 4 days, you can go ahead, of course. If it's not been stopped, then if the anion gap is more than 12, or the ketone beta hydroxybutyrate, ketone bodies are more than 2 millimoles per liter, that this also we get a what do you call the strip. The strips are available now, like the blood sugar strips. It's a little bit more expensive, of course, but then they will tell you immediately on the table that, oh, his ketone bodies or his beta hydroxybutyrate are more than 2, and definitely he should not go ahead for elective surgery. And if it is definitely to go ahead, then we need to start on insulin infusion dextrose and typical hydration and all those things. So the high risk patients who can develop this are patients who undergo high risk surgery or bariatric surgery. Prolonged pre-op, post-op fasting is expected. For example, cardiac surgery, often we are not extubating. If you're not able to extubate them if you work in a program where early extubation, early mobilization is not done, then you can expect a prolonged post-op fasting, or the patient is very high risk, low EF, is extubated after a few days, an overnight ventilation. This patient can have this euglycemic ketoacidosis. Is the HbA1c not controlled, pre-op sugars more than 100, sepsis, MIS, etc. So this is one thing, a message I wanted to give, that SGL2, even this, we start looking out for these drugs and stopping them 3 days prior. In all high-risk patients, we can develop a preventable complication. Oral anticoagulation, bleeding risk versus thrombotic risk is what we are looking at. The oral anticoagulant started with a specific purpose. When we stop this, we have to be sure that we are doing it safely, and also we are restarting it at the end of the period. So of course, then somebody takes the responsibility of stopping it. The same unit has to be responsible for also starting it. So we have to be very sure that it has been restarted in the preoperative period. What these guidelines say, it is not necessary for stopping the antithrombotic for the patients who have got a mild bleeding risk. It is not necessary for us to bridge each and every patient who is who comes with a warfarin or a warfarin, because these patients might not actually, you might be getting this patient to high risk zone by doing the bridging. Rather, you can just keep it simple. So all these guidelines are available in this ACC AHA. For example, in this you can see they are seeing warfarin has been started for a low or moderate thrombotic risk, and warfarin is started for a high thrombotic risk. And as per the surgical procedure of high, low, or minimal bleeding expectation, this is how the stoppage of the warfarin has been done. Okay, and in this, if it's got a high thrombotic risk, here you have and a very high bleeding risk, you can see that he has stopped the warfarin and started the low molecular weight heparin. So these kind of guidelines are very easily available. So what we need to be aware is which of these patients are got a very high thrombotic risk in which you need to do the bridging. A bridging would be advisable. So these are basically the only categories that are there where the coagulation is the thrombosis is to be considered. One is a venous thromboembolism if it is recent. If the patient has got a rheumatic valvular disease, or has got a mechanical mitral valve, or has got some other things like a severe thrombophlebitis or antiphospholipid antibodies. So there are specific indications where we know that the patient has a high thrombotic risk. And this CHAT-DS2 score also helps us to in the atrial fibrillation. And this score we like to do because it tells us in the patients of atrial fibrillation if they're likely to be thrombotic. So anybody with having a left ventricular thrombus or even a LA thrombus, we need to be then shifting them onto bridging therapy and then getting the surgery done. So elective or time sensitive surgery. So it's a surgery where, like I said, um, that we are allowed some time to get it. The patient cardiologist surgery and the anesthetist need to decide about it. What are the question that we asked is what angioplasty was performed? Was it high risk, a long segment, etc.? What was the indication, acute or was it a plan? This is a new thing that has come, that we need to know why the angioplasty was done. Was it an acute indication the patient was rushed in the status, and or what is the plan? The patient was walked in and after a few days he got it done. And when was it done? What and if then about the surgery, you have to ask whether the surgery is elective or time sensitive, and what will happen if what will happen to surgical outcome if the surgery is delayed. For example, the same CA stomach example only we'll see in this. So this chart tells us about the optimum timing for elective or time sensitive non-cardiac surgery. Okay, and so I'll not talk about the bare metal of the balloon because this is hardly seen nowadays. But if this patient has had an acute has an angioplasty with a drug-eluting stent for acute phenomena. He just came with crashing chest pain and then got the angioplasty done. Then a non-cardiac surgery has to be delayed for at least 12 months. Whereas if it's for an indication which was not acute, it was a planned one, then probably the non-cardiac surgery could be delayed for about 6 months. And you could go ahead with this planned surgery for about 6 months. However, for a time-sensitive surgery, the recommendation remains same, irrespective of whether it was for acute indication or chronic indication. A non-cardiac surgery, time-sensitive, has to be delayed for at least 3 months if you have a drug-eluting stent going on, and that too you have to see if your aspirin can be continued at least for this. And you should not perform any non-cardiac surgery within 1 month of a drug-eluting stent, whatever the indication. I hope this is clear. The other line of thinking is that we need to discuss with cardiologists about the stent type. Sometimes the older stents are, and this is an evolving area because newer and newer stents are giving newer and newer guidelines. So we might have a change in these guidelines depending on the quality of the stent, the length of the and the coronary status, etc. So I'll just like try to end with this case of a 66-year-old lady with shoulder surgery, just to tell you how difficult the scenarios are in practice. Now blood pressure is 150 at 64, pulse is okay. She's got a room as such as 98 when she's sitting. She doesn't move around too much, but meds is around 4 approx. That is what my junior informed me. She got specific non-specific ST changes, some LVH, hypertensive on medication. She was operated in AVR a year ago. So somebody who's operated AVR and completed 1 year, you'll be very happy because her aortic stenosis is relieved. This patient now can undergo anything. That is what we usually think. Echo is showing a EF of 65%, normal functioning prosthesis, moderate LVH, and it shows an impaired LV relaxation. That is what, again, I was informed, and a left atrial enlargement. So should we go ahead? We should. It will do well to remember that anybody with a diastolic dysfunction has got limited cardiac reserve, and diastolic dysfunction can lead to diastolic failure if that appropriate management is not done. Now it just tries to see a hypertensive female 60s, and this is a classic phenotype that we see diastolic dysfunction in, and they usually have some exercise intolerance, inability to do exercise beyond a certain level. And this usually we brush along as this is because of the age, this is because of COPD, failure patient, etc. So when you look into her discharge summary, you reveal that she had a stormy course post AVR. It was not smooth at all. She was difficult to wean on the ventilation. She had a low cardiac output, pulmonary edema in the ICU, atrial fibrillation. She was managed with amiodarone, diuretics, best. This gives an idea of typically how a diastolic dysfunction would be present. And this diastolic dysfunction will not go away because she's still an elderly lady. So this patient needs to be carefully monitored. And any patient who's elderly, you have to look out for the diastolic dysfunction because as you saw in the first example I showed you, they will have hypertension and a very low diastolic pressure. This means that they're severely compromised peripheral circulation. And in this, the LA apparently does not enlarge, but if you find a LA which is enlarged more than 50 mm in the echo, then you have to start thinking whether there is a diastolic component, and you discuss if it's a severe form of diastolic dysfunction, then this patient will be a high risk. Then you have to counsel the patient properly and do her BNP, and then find that it's more than 200. This patient needs to be optimized by diuretics and weight loss and so on and so forth. And you have to look to the patient, listen to the patient to see whether the basic problem, of course, is a non-compliant system in this. So how do we approach? I'm just talking about the planning, not about the management. We'll do a detailed examination, weigh the patient, see if there is any recent weight, explain the risk that she runs because of the diastolic dysfunction, prepare for advanced monitoring and post-op ICU. This can't be an on-the-go decision. This has to be very prepared. And so stop the blood thinners as recommended by the cardiologist, see if any other cause of bridging like atrial fibrillation is there. Careful fluid management. Don't overload her. Don't underload. Diuretic dosing. Be careful because if you give a diuretic on the preoperative on the operative dose day, again she might be having a pre-renal cause of renal acute kidney injury. This is an antihypertensive medicine like we already decided. RAS or R needs to be stopped or to continue. We might have to give a half dose like I suggested. If she's an SGL2, stop 3 days prior. Decide on interrupt target. Now this is how we plan. We decide to keep the target. So the 70 target, which is a famous thing that we do for diastolic dysfunction. That means you try to keep the pulse pressure under 70, keep the diastolic pressure above 70, and keep the heart rate around 70. So something like this, we can always. So the planning becomes an important part of the optimization as well. Decide on the combination of NTG and vasopressors. Procure lucitropic agents like milrinone. And of course, we want the best surgeon to do it, do a clean, quick, and efficient job. And this is an excellent teaching thing for the senior and the junior both, because together we can see how an expert manages a patient with these conditions, and it will be great learning for everybody. This take-home message I have copied from the same age guidelines. A stepwise approach to perioperative cardiac assessment is necessary. You do the RCRI, find the patient has got high-risk categories, whether he needs more investigations, and that will decide upon his functional capacity. How much is the patient able to, how many meds the patient able to do. Your cardiovascular testing should aim to avoid overscreening and overtreatment. Stress test will be done only if indicated otherwise, not routinely for patients who got a good functional capacity. It won't add much to it. Team approach is important. That's why Dr. Jigi said that always have all these patients, be good to everybody, and have a good team whom we can call at any point in time and ask them to have a look. Like I just call up the cardiologist and tell them, please have a look at this patient. I want to understand more. Call up the endocrinologist and find out the cardiologists and so on. So be in that where they value your opinion, and at the same time you also can be a good discussion point, because we also talk in terms of guidelines at all times. So it is always the risk of MINS is a uh, the myocardial infarction after non-cardiac surgery, and this is a category that's been defined even by in the Cardiology Society. And this is important because the mortality that comes after myocardial infarction of non-cardiac surgery, mostly diagnosed only by an elevated enzyme, is as high as what can be there when there is a type 1 of MI. That means when the atherosclerotic plaque ruptures. That is how important it is. A new atrial fibrillation is a real risk. Please look into it. SGL2, like I said, is stopped 3 days prior. Bridging with low molecular weight heparin is not needed for all patients, only in patients with high thrombotic risk. And this is my favorite thing. Focus echo will be acceptable, even the guidelines soon. So you have to start to do it and become good at it. So my prayer for you is that may your OT always be a happy place. Thank you so much for your patient hearing.
Thank you, Dr. Shetty, for that wonderful comprehensive lecture.
Thank you, madam.
And can we have comments by Dr. Balaji, sir?
Yes, madam. Dr. Vijay, it is very nice, and you have covered almost all the points. Only maybe a few things I wanted to add, or I wanted to comment is, one is, as you rightly told about diastolic dysfunction. But as an anesthesiologist, I also feel that clinically you should always look for signs of failure in the patient. And if there are signs of failure, even baseline SpO2, if it is less than 95, there is engorgement of vein, edema of feet, even fine crackles.
Yeah.
All this indicates that these patients need pre-op optimization before surgery. And unfortunately, many of the times this on echo only diastolic dysfunction is mentioned, but the degree of diastolic dysfunction is not mentioned. So as an anesthesiologist, it's a bit challenging scenario at that moment, but we have to personally evaluate this patient on individual basis. Second point you mentioned about size of LA, and if it is more than 50 or 45, very high chance that this patient may undergo atrial fibrillation during the perioperative period. And I feel that optimization of electrolytes will be a very good idea. And suppose these patients we are putting on diuretics, on the day of surgery, we must repeat his electrolytes and keep his potassium maybe around 4.5, giving additional magnesium. This is very, very important to avoid arrhythmia in these patients. Third point which I wanted to make, you talked about SGLT2 stopping for major surgery. But what is your opinion for minor surgery where we are not keeping patient for not NBM for more than 6 hours, or daycare procedures? There, I think, should we continue even though it's a moderate level of surgery? That clarification I want from you.
Yeah, so like I said, the most high-risk patients are the ones, like I already mentioned, somebody who's got a, so if you're,
Yes,
if,
bariatric surgery you mentioned, yes.
So even if your patient has got a high sugar, he's got a high HbA1c, and he's undergoing a surgery which is modest, and you're going to send him home on the same day, I'm not very sure whether this will be the stoppage of 3 days will be recommended. But in all fairness, it is to be done. Why? Because this is exactly the most difficult patient, that for somebody will go home and develop the DKA. And one of the things that happen in euglycemic diabetes is just tiredness, and that
Yes.
tiredness might get unnoticed for next 24 hours, and this patient who's going home might actually be at a much higher risk. So either we have to have a very good monitoring of the patient at home also, and the other thing that it's mentioned is that SGL2, if it has been started for a non-diabetic indication, for example, for heart failure, or for
Obesity.
chronic failure or obesity, maybe the chances of developing this is much less. And for those patients, definitely you can do what you said, that you not be, if you're not stopped, then probably you can still go ahead. But what I do for is, and most of the patients that will come, at least I see, are major surgeries. So for me, it's very easy that to stop it. I always refer them to endocrinology to, because if he's a diabetic patient who's on SGL2 and you stop medicine, then it has to be replaced by injectables or something. That somebody has to take responsibility for the monitoring. Like it's a big responsibility of stopping a drug that somebody has started. So better involve that same person to do it. And for this also, I would probably take the opinion of the endocrinologist. See, I have this patient who's not stopped it. I want to go ahead. So you involve somebody, don't take it on yourself is my message.
Okay, okay. Yeah, and you rightly mentioned about the failure is very high risk factor during perioperative period. As an anesthesiologist, we must identify diastolic as well as systolic failure, and we can refrain or we can postpone those cases because outcome is directly related with the failure. Thank you very much.
Thank you, Balaji, for this comment. Thank you.
Dr. Charulata, madam, would you like to comment?
Yeah, Vijay, very excellent, really talk, very vast topic. And I especially like your points that the anesthesiologist first has to be prepared to conduct a case like this. Having developed the expertise in the transthoracic echocardiography also is very important. One of our resident wants to ask that in municipal hospitals, we frequently get very elderly patients with a hip fracture in the emergency who typically give history of having a syncopal attack and then falling and getting a fracture. Now there is always a conflict of interest between the orthopedic surgeon and the anesthesiologist. So in such patients who they want to take up, say within, ideally it is advised now to take up the patient as early as possible to prevent the pulmonary complication in these patients. What would be the optimization process in such patients?
So that's an excellent question, madam, because this patient defines how a efficient hospital should work, basically. So first of all, I should have a process saying that my a patient comes, then I will be operating him as early as possible. So supposing he has got high sugar or he's got a low EF, whatever it is there, it has to be properly charted. And based upon our assessment, we can decide whether we can go ahead now or we can go ahead after 24 hours or so, because even that is not a bad period, 24 to 48 hours. So one of the common things that happens is that they will be on clopidogrel or clopidogrel, and most of us want to do this under spinal or a block which is now becoming popular. So even there, if the spinal is to be given, then we might as well have a couple of days to at least for that effect to go off. So we just try to buy that off and give him a pain relief and then a block and then try to relieve his pain. But your point about whatever I have got to optimize, I will do that based on his history. Supposing even my focus scan shows that his EF is okay, his RV is not dilated, and BP is okay, other parameters are okay, he can still go ahead with the surgery, because we know that with each passing day, the risk of having comorbidities increases. So that's a balance that we do with this part. And for me, it's a very clear that if you've got excellent orthopedic surgeon, like most of the public hospitals will have, and these patients will be from a social strata that they cannot spend too much time in the hospital also, and giving them, of course, we will this is my way of thinking that we'll probably benefit more patients than harming by operating them early. At the same time, our skill set should go up to, say, get a NT-proBNP quickly, or if they see ECGs, get a cardiac troponin. All these things are available in our ER, so we get them done quickly, and rule out other injuries. Stop the patient, and the anesthetist is confident to take it up. Of course, we can take it up, and we will and in patients who have underlying diseases, the surgery and the optimization can go hand in hand. So it's not that you do optimize and then operate him, meaning the optimization will continue well into the post-op. But the one important thing is his fracture is fixed, embolism chances go down, and he can be mobilized early and start on his feet. All those things can happen very quickly if we have a system in place. But unfortunately, everybody has his own way of thinking and doing it. So having a good team approach is very important for this patient. A lot of high number institutions in many places work on this principle only, that we will offer a early surgery as safely as possible for almost everybody.
Thank
Yeah, sir, I want to know if can we start on drug like maybe Mildrenone or something if we know that the patient has a uh, low EF to optimize.
So Mildrenone is a drug which is it requires some experience to be used with. It's not like adrenaline or adrenaline that we are using routinely. So Mildrenone is a drug. What it will definitely do is somebody who's having a right ventricular dysfunction, a right ventricle is struggling in the face of a elevated pulmonary artery pressure, it will help. to reduce the pulmonary artery pressure. It also gives a myotropic, a lucitropic effect. It also relaxes the heart. So all in both ways, by increasing contractility and causing relaxation, it will help the heart improve. But unfortunately, one of the common effects that a side effect it has, especially in this perioperative patients, because most of them will be dehydrated, hypovolemic, it causes severe hypotension. And this hypertension cannot be managed just by giving volume. So you will have to give a, so what most of the times we have to do is that some bit of noradrenaline or some adrenaline just to shore up the BP will be required. And that is why that's what I'm talking about, the experience. If you got a very high BP patient and then high blood pressure, and the patient is otherwise looking okay, and you want to now start a mildron, definitely it will help you to have a lucitropic effort. But somebody having a good saturation, a good will not probably require it. We can go with the lower drugs before going up with the Milron. But when we get stuck with the RV dysfunction in the face of in this scenario, we will probably have to look at giving Milron. Yes.
And I also want to know about statins. It was not clear whether we suppose a patient is on statins, we continue statins. That's what you told clearly.
Yes.
You don't start statin, or you can start statins with the patient's.
So the recommendation is that we can start statins if the patient would have otherwise required it. Meaning somebody's got a deformed lipid profile, he's got a coronary disease background, or there is a assessment of somebody who is liable to benefit from a statin therapy. If he fulfills those criteria, meaning if he had gone to a medicine person, somebody would have started him on a statin, that same criteria can be used to start a statin on this patient. Unfortunately, why I'm against the statin is because one, he'll not follow up with me, so I can't be responsible for it. And if he develops some, because some patients develop some reactions, or the first couple of doses are a little dangerous, and muscle pain, severe muscle pain. So you can imagine somebody I start chatting yesterday, and today is having some body ache and severe body ache, and then it becomes a dilemma about going at the surgery. So it has to be done with, if there are adequate period is available, most certainly somebody who's should be started. But we don't go there because this is a responsibility that we cannot take. Like, I'm very happy to take the responsibility of smoking cessation, like Dr. Jiggy said. Anybody comes smoking, I make it to point to spend 5 minutes, because that time the patient can really decide to quit if you really pump him up nicely. Whereas this statin is something that is a cardiac drug, it will make my life easy. But even initiating drug has to be given to a cardiologist, and you know how busy they are and how much time they will do. They will just say, he's fit for surgery. But I didn't send him for fitness. I have already given the fitness. I wanted you to initiate something that, so that initiation in the periodic period is not a very, they're not very big fans of that as such. So I think I'll be very happy to start anybody on statin who deserves it. But I probably want the cardiologist to be also in the picture for doing that.
Yes, yes. There is one question. Saurabh, can you read the question?
Just give me 1 second, madam. I'll just be back. 1 second. All right, I'm back. Sorry.
Somebody at your door.
Anna.
There is a question. Can we predict peripartum cardiomyopathy?
Oh, peripartum cardiomyopathy. Let me see. So there are some genotypes in which it is this Takotsubo's can occur, or a cardiomyopathy can occur, but I'm not very sure about predicting it at all. But serial echos can of course predict it, and as you know, it happens mostly towards the end, towards delivery and towards the stress of the pregnancy, and it can happen after delivery also in the next few couple of days also. So prediction, I have to read about it. I have read about it, but I don't remember right now. But I think whether if you're looking at something like, you can see the entire heart is, for the 9 months, it has taken the load of the double circulation and everything else, and it is just that the stress that happens when it can the cardiomyopathy can happen. So stress cardiomyopathy can happen for anybody. It can happen for anybody who's has a very severe emotional or loss of a partner, or a severe emotional issue can come about, or financial things can come about. So those bad news can cause this broken heart syndrome or Takotsubo's cardiomyopathy. Or even in the pregnant, it is quite. But good news is that it is reversible. There are drugs available to reverse it, and most patients The worst case scenarios can go for an ECMO and come out of it, and very rarely they can come for a transplant. But prediction, I am not very sure. I'm sorry about that.
Should I add, madam?
Yes, sir, please.
Rather than prediction, I think we should suspect in few patients. Means our problem is rather than predicting which patient we can suspect this peripartum cardiomyopathy. At-term patient who has got disproportionate tachycardia, maybe 130, 140, who has got cough which is recently started, edema fit, whose appetite has decreased. Actually, it should increase, but which may be due to hepatic congestion, it is decreasing, and a lot of edema fit and gross engorgement. In this, probably in those patients, you can suspect and you can advise echo, and probably this can be the answer.
Yes,
One
I
or two
think
patients we could able to find it out. That is why I'm telling you.
That's why the role of our echo being in our hands is also important, because you can do the echo any
Yes,
number of times. Like
yes,
in the
yes.
morning, the echo might be normal. By evening, you'll find a totally different picture. And if you're seen that echo, you'll pick it up very, very quickly.
the rule
So
of
can I add one thing? These patients with peripartum cardiomyopathy classically they have epigastric pain. So, like if they have recent onset epigastric pain
Yeah, it is due to
and
Liver
reduced
congestion.
congestion. Yeah,
effort
yeah.
Liver congestion.
tolerance,
Liver congestion.
so yeah, so there you can suspect it. And I wanted to ask a question. Can I ask?
Yes.
Yeah. So, Vijay, excellent lecture. Very well covered. Um Many a times we get patients who undergone PTCA, and within 2-3 days or few days after PTCA, they come with complaints of melena, and they are taken up for scopy, and the drugs are antiplatelet drugs are stopped. So we do not have a fair idea about their 2D echo status, and the antiplatelet drugs are stopped, and they are for colonoscopy or for esophagoscopy. So, what is your take on that? How
So,
to go about it?
so if I have to answer that, the one thing is that this is a must-do surgery, must-do procedure, number one. Scopies and such are usually among the low risk category, but the ones who do, we know that it is not actually that much, because if there is something to be done, the time can go on, and the pneumo, everything can, the air and everything else can cause a lot of problems in breathing. So if the patient is not of a is otherwise stable, the bleeding is the only cause, then he's like just like any other hemorrhaging patient. We have to manage him by giving the blood and everything else. That part is there. As far as the thing about engaging about his causing his him going into a re stenosis of the stent and causing another MI, which is also not uncommon, because it is very clear that somebody who's undergoes this has to have a dual antiplatelet therapy for at least 1 year period. So, like you rightly said, when you stop and you're doing it, actually you're not given any reversal agent. The patient is still under the effects of the drugs, and usually it is. I mean, he stopped yesterday and today you're doing the scope. It's almost that kind of a scenario. So he will still be protected among by the for the effects of the for this thing when you do the, and the risk actually is that after you started, when do you restart it? And even a low molecular weight heparin that you might give will not cover the action of the antiplatelet. So it's a risk that we are taking as a life-saving thing. For example, somebody has to undergo a post-plastic, he has to undergo a craniotomy. We stop it and we go ahead and we do it. And we try to keep the hemodynamics under control with the hope that the heart is not stressed. And that's the only thing that you could do. You cannot do independently anything for the stent, prevention of the stent occlusion. We have to do what is important for the life rather than for the stent.
Okay, thank you.
Balaji, anything else you can please add whenever. Actually,
Yeah,
I forgot to give that statement in the beginning, that anything that comes, Dr. Balaji will also answer.
yeah.
this SGL2 drugs also they prolong the gastric emptying. So it is said that the gastric emptying is prolonged for 12 hours, and so we have to be careful and
Yeah.
maybe do a modified induction.
So if we stop it, that's of course there is no problem. And
Yes.
most of the times, 12 hours would have gone for the last dose that would be there. And one of the things that we try doing is what we try to do the ultrasound and try to see if the contents are there. So that's one thing again with the ultrasound will help you to detect incomplete gastric
See the antrum, whether the stomach is full or not. Yes. One very important message I got is that if there is heart failure, diastolic dysfunction, and early heart failure, this is the most dangerous patient rather than a patient who has a stable angina. Because we seem to label all patient as okay, cardiac patient, patient with ischemic heart disease, but a patient who has early heart failure is a more dangerous patient. That's what I gathered from your lecture.
They are not easy to detect. That is what is also important. That
yes,
we might. The other thing, though it is not to do with optimization, I just wanted to give a message that in these difficult patients, in the olden times, you know how we used to, at least in my training, sometimes we were told to give less anesthesia and so on. So actually, that is counterproductive. In a patient who can just go into failure by tachycardia, mere tachycardia, and you try to give less anesthesia, is not going to work. You have to be very confident that I am monitoring enough and I'm doing the right thing by doing whatever I am doing. So there are plenty of drugs to choose from and options, but we have to have our hand on the pulse of the disease as well as the patient.
So any cutoff for the pro-BNP or any patients in whom we do pro-BNP before?
Yeah, so this patient I said, this last patient example I give is a typical example where you could do a pro-BNP. So if you get a high pro-BNP, you know that the patient is high risk. If there's a respiratory cause or if there's a failure, you can clearly say this patient is high risk and you can discuss with the patient. So what it helps us to do is not to postpone the patient, but it helps us to say that, okay, this patient is going to require more monitoring. Can the surgeon do something else? For example, if he's by obstructive uropathy, you might just do a channel rather than doing a prostate. Whether this patient and this patient is going to go into ICU, probably if he develops is intubated, then probably I will be safer to ventilate him and hydrate, rather unload him and those kind of things. He might be higher indication for giving a little support to have a better BP and so on, having a ABG monitoring. So your optimization is not only about giving a green signal, it is also about our plan to how to handle. And that plan should slowly start crystallizing as with the experience. You realize that, oh, who can do this patient? What monitoring should I be doing? And what do I expect in the post-operative? So if that line of thinking is very evident in your way you work up the patient, you usually will be, if the patient has any problem, you know you are anticipated and you send him to the right place.
There are a few questions as well.
Yes, please go ahead.
Very common question. Should we do to deco if patient is posted for cataract surgery? If there are ECG changes like LBBB, multiple VPCs or TVA inversion in multiple leads, but patient is asymptomatic.
So, Balaji, you take that. Come on.
If patient is totally asymptomatic, he has got a good effort tolerance. Cataract surgery is a very low risk surgery. So there is no need to go for echocardiography. But at the same time, let me tell you, most of the patients who are coming for cataract, they are coming for evaluation, maybe for the first time. So they get evaluated and you find so many things and you subsequently patient requires echocardiography. But there is a stable patient who can walk around, who can easily going 2 kilometers daily exercise he is doing. I don't think there is need for echocardiogram. It's such a superficial, low stress surgery. It won't cause any problem.
So now this is an excellent answer, but this has to be backed up with our own policies. For example, like Balaji, remember that was one case, 20-year-old for one hernia, he had
Yes.
arrest, and the judge is asking the anesthetist, why didn't you do an ECG? Like none of us would do a ECG for that patient. So what I do for at least, I mean, for the young patient, that's an ASA1 patient. Like my goal is that ASA patient should not have any harm. Like you can accept anything, but ASA patient should not have any harm. But we can still have things which go out of our hand. And so for this patient, what I tell them is that, see, uncle, you are 80-year-old, 70-year-old. You have not worked up your heart ever. So I don't need this echo for my sake, but for your own sake, you can get it done, health checkup done. And many of them have done, like Balaji said, most of the patients who come have their health checkup done. But I don't need it for the purpose of operation. I'm going to give you fitness. You can get it done because as per our policy, you're eligible to go ahead with the surgery without having an underlying thing because your work status is okay, your work tolerance okay, you're asymptomatic. You have minimum ECG changes, but which I expect in this age group. But because you're having a good functional capacity, so anybody with a good functional capacity who's come to you walking does not need any investigation if he's going to undergo a cataract. I agree with Balaji there. But at the same time, in this medical legal field, you can just be a little smart and tell these kind of things also. It might not be officially a good advice, but as per, like, if somebody says I have this investigation, I said you are fit for other cataract. There is no need for anything else. I hope this question's
One
answered.
more question in chat. If patient has cardiac problem like ischemic heart disease, LBBV, post-CABG, arrhythmias, history of AF, is it necessary to take cardiologist opinion medico-legally?
Cardiology opinion. So this patient has got all these problems.
Any of these
Any
problems.
of
Okay, IHD, LBBB, post-CABG. Post-CABG, I will be happy not to take the opinion, because anybody who's got a post-CABG and has got good functional capacity, has been following up, has got a recent echo, I don't need anything. Patient has got LBBB, otherwise again asymptomatic, he is fit, doesn't have any what do you call palpitations and arrhythmias, or has undergone investigation of the LBB, I don't need him to have. Ischemic heart disease is important that you have some cover. Why? Because if your patient has got ischemic heart disease, meaning he's got proper symptoms and he's undergone angiogram or not undergone angiogram, there are multiple variations that ischemic heart disease can come. It is always better to get it evaluated unless it is an emergency where you cannot do the evaluation in that thing. Arrhythmias, again, simple arrhythmias like simple atrial ectopics or type 1 or blocks will not have any ramifications. So you can, only thing like Balaji said, you have to make sure that the electrolytes are okay for them. In fact, that is probably more important. Atrial fibrillation is important because you need to rule out causes of non-valvular causes of atrial fibrillation, for which again you might need a cardiology opinion. And sometimes really other things like undiagnosed hypothyroidism or pheochromocytomas also come up when there is atrial fibrillation. So it's a very good way of picking up this hidden things. And if you're taking a cardiology opinion, it is not like you are a inferior anesthetist. Let me tell you very, very clearly. Now, Balaji and me have been doing cardiac anesthesia for so many years and decades, so we know why to disturb our cardiology friend. That is what our purpose is. That by not sending, not to show that I am better than anybody. But anytime you feel that there is a need, you have to send him. But you have a thought in your mind that what is it that you are wanting him to say. When he says can go ahead, that means is the patient sufficiently optimized? So why I would say is that if he goes into AFib in the post-op, you need somebody to be aware of this patient's condition, so he can quickly institute a therapy or go ahead with investigations. If you develop STD changes in the post-op, at least you can say that I have shown it to cardiologist. He has said that okay, he will be around, he'll be going ahead. Though there is hardly that anything somebody can do after a major surgery when somebody develops a MI, but a cardiology opinion is good in that purpose. In that medically, most certainly yes, I would be happy to go ahead with this in any of these conditions. If you are happy to, if you are not sure about it, what is going on, please go ahead and take an opinion.
this question was for medical purpose, medical legal purpose.
Better to take.
So,
Hello, sir. I want to ask one question.
Yes, sir, please.
Go ahead.
Sir, this is regarding actually my daddy only. He is 82-year-old and planned for TKR. So I investigated him. He doesn't have any of the comorbid conditions. He's otherwise active. So on the routine investigations, 2D echo was normal and ECG was also normal. So we planned for a stress test, dobutamine stress test, because of his age. And the cardiologist suggested that better to we'll do a treadmill stress test, not a dobutamine. He was comfortable with treadmill test. So with the treadmill test, the target was 140, his basic pulse was 64. At in the first stage, he reached the heart rate about 108, and in the second stage, he developed at the heart rate of 118. He developed a little bit of uncomfortable and ECG changes. So we stopped the stress test, and the cardiologist advised we'll do for angiography. So I just wanted to know after reading this lecture that what should we do and how should we go?
So who was advised that Rajesh? Who was advised the stress test?
The cardiologist.
Then you have to ask him only what he wants to do, because
he has advised we'll do a coronary angiography.
Yeah. So and the coronary angiography, the purpose is to detect lesions, coronary lesions, correct?
Yes.
So what happens, at this age, like at my age, if you do my angio also, you will find blocks. So the purpose of doing angiography is to identify correctable lesions. So if I see, like, I might be having 40-50% block, which will be asymptomatic. If I do an angio, I find it, nothing will be done for that. Only you will go at the operation saying that I found 50% blocks in this guy's arteries. Now, he's going to undergo unilateral or bilateral TKR.
Bilateral.
So bilateral TKR is usually done in patients who are not so mobile, no? And most of these patients are unable to do a stress test. So if he's walked the stress test, that means hats off to your dad, because the dobutamine stress test is done for these patients in bilateral, especially because they are bedridden, sort of not moving much. I don't know their functional capacity. Now, if he's undergone a stress test, that itself is a success for me, because I will today do a surgery in a way that will not sort of strike the heart at for such a long duration at such a high rate. So the importance in that anesthesia has to be well managed for him, most certainly. And if an angiography has to be done, because now see what happens, you're not a doctor now, you're somebody who's come saying, and now the cardiologist said, I will want to do angiography done, then of course you will get it done. And you might find that there are some blocks which now need to be addressed, which will now lead to intervention and postponement of the operation by at least a minimum of 6 months to 1 year, which is a thing that you should accept. Because even Balaji will agree that we have got patients who undergone TKS and within 3 months they come for a CABG. Balaji, hai ki nahi? We get those patients who undergone TKR and come for, because they undergone that surgery, but they had underlying lesions which were sort of not important at that point in time, or were not, he had a good effort tolerance. So we did not push him on that cardiology workup way. But of course, this is a plus minus situation. Rajesh, do tell us what happened.
But my opinion is, if it is a stable IHD without much risk factor at 82-year-old patient, asymptomatic, there is no need to go for angiography. And there is one very interesting paper recently came, I think. If there is a stable IHD, stable coronary artery disease, patient undergoing a moderate risk surgery with some hemodynamic fluctuation, still nothing will happen. Unless it's like left main or critical left main equivalent, then only something happen. But if left main equivalent is present, patient will be symptomatic. So any person who is asymptomatic with no comorbidities like diabetes, hypertension, obesity, just 82-year-old patient, I think there is no need of angiography. He can directly post for bilateral TKR.
But what happens?
Can I just
Yeah. Go ahead.
I'm sorry. Can you go ahead?
Yes, sir.
Rajesh, you tell us.
I was just thinking, sir, now we are in a situation that there may be some issue over there. So by doing angiography, if we'll come to know there are some blockage which are like 70-80%, which can be managed medically. So if we know something is there, we will be more careful. Is it like that way, or we should not go blindly and go ahead with surgery?
No, there is no need to go for angiography. Even if there is lesions, which is stable coronary artery disease, around 60-70% lesion, you take all the cares, avoid hypotension, and this surgery can be easily done. Basically, why we want to do angiography? Because we wanted to decide whether surgery should be done first or coronary artery disease should be addressed first. This is the main dilemma that we want to solve. Now, this is a elective case, and this stable, suppose even if there is lesion 60-70%, do you going to address that lesion? No. So I think it is a elective surgery in a stable coronary artery disease probably we are dealing with. You should go ahead with elective surgery.
No, means like if there is need to start some statins or single antiplatelet drug for some time, then we can start, and after some few weeks we can go ahead with surgery. That will help us, or there is no need for that.
If it is lipid profile is deranged, and you said that there is no risk factors, and the person who can increase his heart rate from 60 to 118 without much symptom, I think he is a good candidate to he can undergo surgery without invasive means angiography.
Yes, thank you. Thanks a lot. Vijay, you want to add something?
You tell me what happened later on.
No, I have not done. I have not done angiography till now because he's not ready. So waiting for his willingness for that.
Who's
So I
not
want.
ready?
My daddy is not ready for that.
So
Waiting for.
this is one point. See, this I always talk, and this time also I had said this. It was mentioned in the last guideline also that there are a lot of people who take decisions of the patient without involving the patient. Now, if you are told your daddy first, अभी आपका एंजियोग्राफी या अपना स्ट्रेस टेस्ट करेंगे, उसमें कुछ निकला तो एंजियोग्राफी करने की जरूरत पड़ सकती है, उसके वजह से हम लोग प्लास्टिक करेंगे, जिसकी वजह से आपका ऑपरेशन 1 साल के लिए हो सकता है पोस्टपोन, या बाईपास अगर हुआ, बाईपास का नाम सुन के बोलेगा नहीं करो, मेरे को नहीं करना है. He will say, I don't want any testing because you will push me to a heart. I'm not interested in that. I've lived 80 years. I'm happy. So this is the typical answer that, and this is what if you had come to you as a patient, you would have said all these things. And see, Rajesh, we can go wrong sometimes, but what happens that we have to be very careful that uh, everything is done in the correct manner. So because it's a dad, we will want to be more careful. But just that what I said, doing more investigations does not make us a careful anesthetist. It may lead you to do over treatment or over diagnosis. And for this patient example, if you're like Ravari said, you can start your statins and everything else. You can do all the optimization. You can BP is borderline high. You can start him on a beta blocker, make it comfortable, and you can go ahead with a one leg surgery first, which is less stressful, and then go with the other leg after a few days if you want to reduce the intraoperative stress, because bilateral is of course a much more stressful surgery than a unilateral. So we can do that, those kind of manipulations also. And doing a angiography, very clearly it has been said it is to be done if the patient would otherwise have needed it. Okay, so supposing he has ischemic symptoms and his ECG changes, chest pain, then he requires an angiogram, then you do an angiogram. So that is what you would ask, and then decide to do it. So it's your call. Since we have gone ahead till this point in time, and the patient is saying no, so patient ka, please, this is all I do in my OPD. If I sit in the OPD, I always involve the patient. This is what is going to happen. I draw a roadmap or a tree, and then tell this is the pathway. This is the pathway. You have to decide which pathway you have to go. We have a very good expert team here which can manage all situations. But the decision about which pathway to go is with you. And then let him take a call. Very clearly explain in 3 minutes, and they understand this, and then they take a call about going about the stress test.
Thank you. Thanks a lot. Thank you.
Next question.
Are there any more questions?
You are unmute, Saurabh.
Yeah, one more question in a chat box. A symptomatic patient having moderate block in LAD in CT angio, good AF, laparoscopy or open surgery?
So that why is the discussion about laparoscopy or open in this patient, Dr. Mohan? Is because we are commonly doing open surgery, lap surgery only, and open surgery will get its own disadvantages of post-operative pain and so on and so forth. So laparoscopy surgery, and it's always a SOS open, right? So laparoscopy surgery, if it's amenable to laparoscopy, I'm sure that this patient will do very well with just a laparoscopic surgery. In case he doesn't handle the pneumo, then we can go with the low pressure pneumo. Still try. I would give my best for this patient laparoscopic surgery for the very reason that he's got a coronary disease and on the CT. So I would want him to have the fastest, quickest, and most efficient surgery and most painless post-operative period, because post-operative period is when the most of the problems can occur. So I will target that only. So I'll go for a lap surgery.
Yes, without any risk, he can undergo laparoscopy.
No, sir, this patient was for a hysterectomy, laparoscopic hysterectomy. And on ECG, she had some changes. So stress is positive, and then cardiac CT showed LAD block. And laparoscopic surgery is definitely more demanding. That we did patient under spinal hysterectomy, simple hysterectomy. I think that was a safer at the nursing home level. because we never know whether that block will create a problem in post-op. Because once I did a cervical fusion, cervical spine surgery for 4 hours. Then immediate post-op, patient was sinking, so we did ECG. He was having infarct. That patient was diabetic and elderly patient. We had to do post-op angiography, cardiac catheterization, and POBA was done because he was given. Because immediate post-op now, so anti-platelet was not supposed to be given. So only POBA was given. Later on, he needed stenting also. This patient was elderly, but we could have done cardiac CT angio in such cases, because otherwise you will have to face anytime infarct they can have. There is no other. Cardiac CT angio is a non-invasive procedure, can be done instead of angiography.
So my take on that is this: that even in the guidelines they mentioned about CT angiography, that it should be done in a person who would otherwise have it would have recommended in. The problem with CT angio is that it tells you that the arteries are clean, all right. And the second thing it tells us there is a blockage, and sometimes with high calcium score it will not give the blockages. So it can be an alternative. But in this case of your, I'm sorry about that, but I thought that it was laparoscopic cholecystectomy. That is why I said. But what I meant is, what I meant was that you do whatever you're doing normally. That's what the solution. That was the answer was actually, rather than saying lap and open. If you're doing this surgery, whatever way you're doing, there is no contentation doing the way that you're doing just because he's got a modest block in the LED. And the CT angiography, the problem again is that you have to have a very good heart rate control to have a good pictures. Secondly, if it shows something, you still have to undergo a conventional angiogram to confirm.
Finally angiography only.
Yeah. So CT angio or this one, I don't think that we should fall into it. It is not our business. My job is to see that if he goes for angiography, it should be very clear that the patient knows that he will be delaying the surgery by 1 or 2 months if it's a CABG, and by 6 months to 1 year if it's a PTCA. So that part should be very clearly told to the patient, and then based on it is his body, he gets to decide, which is something we seem to forget all the time.
Yeah, but in this case, probably hysterectomy, either it is required for bleeding or time-sensitive surgery. So we cannot wait for months together for this surgery. And moderate, maybe even if with moderate lesion, we should explain some elevated risk during the perioperative period, and we should go ahead with the surgery. And second thing is, you said spinal is more safer. It's not that spinal is more safer or GA is more safer. We should avoid hemodynamic fluctuation, whichever anesthesia you give. If you give a stable hemodynamics during the perioperative period, then the patient will behave properly. But if you are given a GA with a hypotension, you don't take aggressively, didn't manage in perioperative period, you will be in a soup. Or even if you give spinal without hypotension, you have taken adequate precautions, you aggressively manage level and all these things, then it won't cause any problem.
Yeah, for laparoscopy, we need a steep head low position, and pneumoperitoneum will create additional problem.
Yes, but in spinal, at least I feel that it's more dangerous to give spinal to this patient. Because in GA, it's hemodynamics are under control. You can manage everything. You are doing in giving spinal, which is causing precipitous hypotension. On the top of that, you are inflating his stomach. You are decreasing his venous return, and I think it's more dangerous.
Yes, very clear-cut message there. Actually, we seem to think that spinal is safe, but that is not true. And are there any more questions, Saurabh? It's 8:30. Very good discussion going on, but we have to stop.
One last question from Dr. Rajesh Rao, sir.
Yes.
Sometimes there is a catch-22 situation. Patient requiring emergency surgery has acute cardiac symptoms requiring CAG, which shows significant coronary involvement. Cardiologist advises to go ahead with surgery, considering emergency and plasty thereafter. How to handle or counsel?
think this problem is already solved for you. Like somebody's already said that go ahead. So that at least going ahead is not the problem. So following all the properties that Balaji said, we have to go ahead with the surgery. So now the thing is about counseling. I think Dr. Rao will counsel very well because the cardiologist has said and intensivist said and the anesthetist or together will first form a huddle and then very clearly said, because this is one patient that nothing should go wrong as far as somebody having a misunderstanding. So very clearly, Dr. Cardiologist had done the angiography. He is suggesting that it is severe, but then we have to go to the surgery because it is a life-saving and limb-saving. And then the post-operative, the angioplasty is not going to be easy business because obviously, depending on what surgery we will be doing, it might be not be possible in the immediate aftermath of the surgery. So keeping him stable for the next few days will be very important as far as this concerned. But it is certainly not a bad plane, I would say, because your cardiologist is already involved, and we also have a very good idea about what risk we are having. It's a catch 22 situation, but it is a situation where actually the anesthetist skill and his level of understanding of the disease and his management will make sure that he or she emerges the hero for this case because of wonderful management about the patient intraoperative. This is where our skills really come into the fore because he can easily have a event. Your job is to by making sure that you maintain the hemodynamics well, you at least try to keep the events at bay for a few days till the plastic can be done.
What I feel is, as you're absolutely right, now we have to go ahead with the surgery. Now it is the anesthesiologist to decide first the level of care. Means at which place this surgery should be done. It should be done at a multi-speciality hospital where a cardiologist backup, cath lab backup is there, ICU backup repeatedly, intensive backup is there. Secondly, we should go ahead with the invasive monitoring to this patient, putting a central line, putting arterial line, all then focus if require, you can go ahead with the intraoperative echocardiography. All these things are in hand and you explain the risk to the patient. I think these patients can be very well managed. You cannot do such kind of surgery at a nursing home level. So this stratification is to decide the level of care, the level of aggression during the perioperative period, and taking all perioperative care. This is for this stratification is required. Otherwise, I don't think if you take it, Vijay Shetty will do this surgery very easily. He can give anesthesia to this patient very easily because of his expertise in handling so many of cases. So it is that thing is more required for such kind of cases. Yes, Vijay.
Yeah, good point. I think the place, because I thought this angiography is already done, so it is in the same hospital. So obviously that level of care would be of a level that because most patients would not get angiography done in a peripheral hospital. Like it's like he has come to a good place where good meaning a higher level place where the angiography is available. So I think so having more people at your side who are thinking the same way is very important rather than having difference of opinion. So like everybody comes to a goal, you might not agree to it, but you make a common plan and then you stick to that plan, which is very important. I think this is a very good hand, and if somebody's done a case like this, it is very creditable that they have delivered good care in this patient. Now, the patient who was coming for an emergency surgery should never undergo angiography, first of all, as per the guideline, because
yes,
he comes for an emergency, he just goes for the surgery, assuming that you will take all the care. Now, it is probably something he's come with a trauma or with chest pain, and they decided, then they did an angiography thinking that he'll have something, and then they found that it's a perforated appendix, something that it's a life-saving situation. So I think nothing much can be done. There are specific situations where MI is very common. For example, a severe trauma. Even with and other thing is that just because the coronary is normal doesn't mean that he will not have an MI. This is my common very favorite statement because if it's a poor anesthesia technique or the patient has a poor risk and you push him beyond the boundary where the demand supply is not met, even with absolutely normal coronaries, patient can have an MI. So that means the onus of delivering good anesthesia rests upon us, and that is why we should do that for each and every patient, assuming that he's got a coronary reserve problem.
I think we have had a great discussion, and let us stop here. So I request Dr. Rajesh to propose the vote of thanks.
Thank you, ma'am. It was an excellent webinar. We would like to extend our sincere gratitude for delivering an enlightening talk on respiratory and cardiac optimization before surgery in our webinar. Your expert insight and knowledge in this critical area were invaluable. Your presentation was informative, engaging, and thought-provoking, and we appreciate the time and efforts you took to share your expertise. Thank you so much, Dr. Diwatiya sir and Dr. Vijay Setty sir. I would like to thank Dr. Balaji Aswakar sir, our past president of SAMS, and Charulata Deshpande madam, who took who spared the time for this webinar and given their expert opinions. I also like to thank Dr. Anika Niti ma'am, Saurabh Parna ma'am, and all the SAMS members for attending this webinar. Thank you so much.
Thank you.
Thank you, Rajesh. Thank you, madam. Thank you,
Good
sir.
night.
Thank
Good
you
night.
all. It was excellent webinar.
Bye.
Thank you,
Saurabh.
everybody.
Thank you, Dr. Rajesh. Thank you so much.
Thank you, everybody.
Thank you, madam. Please stop recording, Ganesh. Okay, good night.
Good night. Good night all.